we go. Okay, so welcome everybody. My name is Dr. Lori Ann Stretch. I go by Dr. LA, and I am the coordinator of the online counseling program at William and Mary. I also have done a lot more, and I'll introduce myself and talk a little bit about my background a little bit more in a minute. I just want to make sure everybody is getting into Zoom and talk about a few Zoom logistics. When you're in Zoom, please remember to mute yourself so that we can reduce the amount of background noise, but you are welcome to take yourself off mute and, say, hey, Dr. LA, what about this? It probably is easier for you to raise your hand so I can see you and then I'll call on you, but you can also just jump in. Don't hesitate to, okay? But we have a lot of material to cover, so it moves pretty fast. We are recording this. It will be on the William and Mary Online Counseling YouTube channel, so you'll be able to access it from there. And also for the William and Mary students, you'll be able to access it through the program office. So it'll be in both places. So welcome to everybody who's coming in. We still have a bunch of people coming in. We're expecting probably, 75 to 100 people today. So it could be a very big group today. Let's see, what else do I want to say? We will take a break about halfway through. So about 10:30, we'll stop and take a 10-minute break and go stretch and do some self-care. But of course, take care of yourselves throughout the session. If you need to get up and, go do something, by all means do it. I just ask, turn off your camera, walk away, and then come back. I do love to see you on camera. So, some of you may not be with William and Mary, and you may, maybe not used to that, but I'm hoping with the pandemic, most of us are used to being on camera now. So we do welcome that. I love to see you and interact with you and talk to you about things. So please feel free to do that. I intentionally don't do this as a webinar through Zoom because I need to see you. I need to see your faces. I need to, see if you're getting it or if you have questions. I know that we have people from all over the place. We've actually invited several different schools to this event. So if everybody doesn't mind putting where you are, like, hi, I'm in Williamsburg and I'm affiliated with William and Mary, or, you can just put Williamsburg and William and Mary, or, wherever you are in the world. Let's throw that up in the chat just so we can kind of see where everybody's from. If you're with a site, because I know we have some site supervisors, would love to see you. We have prospective students. Thank you for being here. But we just want to see kind of who else here. I know mostly it's a William and Mary crowd, but it's good to always see who else is here. And to all of our guests, welcome, welcome, welcome. We are excited to be with you. Mia, welcome from Canada. All right. Good deal. Okay, so thank you everybody for playing my games, my reindeer games. And I'm going to throw up in the chat the handouts again, just because when people come in late, they can't see the chat for before. So you can grab that from the chat. It's also going to be at the bottom of the page of the handout that I'm showing. So if we ever need it, you'll be there. Okay. Good. Welcome to Chesapeake people. That's where I'm from. And that's my hometown. So welcome to you guys. Glad to see you. All right, so let's jump in. Everybody got the handout? Are we good? Thumbs up? Yes, good. All right, great. If you have any problems, anything happens, don't hesitate to help, ask for help. Some of my more senior students, like say Liz and Talia and Tammy and Jerry, if you guys can just kind of keep an eye on the chat, and if anything comes up, you could yell it out at me, that'd be great. But thank you for your support and help. It's kind of hard to manage everything at one time. All right, so here we go. This is going to be a fast ride. We're going to do 3 hours today. And today is going to be a little bit heavier than what we'll do in the second session of this, or the part 2 of this session. We're going to be covering a lot of laws, a lot of ethics in this particular session. So it can kind of sometimes, be honest, be a little depressing about how hard telehealth can be sometimes. But know that in part 2, I give you tons of resources to help you make it more manageable. Okay. And I'm going to show you some technology in part 2 and some ways that you can, yes, I sure can, Tammy. There you go. So that you can do this more easily. But first, I do have to cover all the things that we have to think about, and there's a lot. Okay. So we will go through that process. I'm going to share my screen. And I do just use the handout. I found that's easier than trying to keep a PowerPoint aligned with the handout. And that way we're all working from the exact same thing, right? So you're seeing what I'm seeing. So here, best practices for mental health professionals engaging in telehealth. Hot off the press, was updated last night. And you can see the handout link is here if you do need it. So one of the things that's been really interesting is I started working in this field in 1997, way before it was cool. Okay. But my interest in this field goes back even farther than that. So it actually goes back to, believe it or not, the 3rd grade. So when I was 8 years old, I was in my class, and we had those reading books with lots of stories in them, right? And one of the stories that we had to read was about a little boy and a little girl, and they were on these things called computers. And they were talking to their teacher on these things called computers. And they were at home going to school. And I was like, wait a minute, how is this possible? Right? And I was pretty fascinated by this. So I reached out to my uncle, who worked at NASA down in Galveston, and I called him Collect. For those of us that are older, will know what that is. I called him Collect and got my Uncle David to answer the phone. And I said, Uncle David, what are these things called computers? And he was like, oh, they're these really cool machines that can do stuff really fast. I'll send you a picture of one. And I was like, okay, cool. So I'm like checking the mailbox because we did not have email back then, checking the mailbox, right, for this picture. And sure enough, a couple of weeks later, I get a Polaroid picture of the supercomputer at NASA in Galveston. That was probably one of the most illegal pieces of mail I've ever received in my life, because you should have never been allowed to take a picture of it. But it had this massive computer with all these lights, and it was so cool looking. And I was so excited about it. That summer, my Uncle David actually sent me to a computer programming camp for 3 weeks, and I learned how to code a computer. And a couple of years later, he sent me a Mac Lisa, which was huge. I mean, I think it was like this big, and it really didn't do too much. And I typed, and I got this computer magazine, and it had all this code in it. And I painfully typed it, made mistakes, had to retype, finally got this little alligator to do this after about 15 hours of coding. But the love was born, right? I had fallen in love with technology. And from there, I went on to go to school. And after I finished my undergrad, went to work for the federal government, did some work there, had the opportunity to do and have some great experiences, got introduced to email and internet, and then started wondering how we could use this to help people learn. And so I went back and got a master's degree. And while I was in my master's degree, I attended the first online course in the state of Virginia that was ever offered. And it was about special education, of all things, and went to that class. And it was like just one long thread of discussion. That's what our first online class was. But I really fell in love with this and developed this online passion and became a really strong advocate for telehealth and online education. In 1997, I had the chance to go to the UK and study, and I worked with a couple of individuals, Stephen Goss and Kate, and they helped me understand how to do telehealth, because in the United States, we had no guidelines. We had no ethical guidance. We had no laws. There was not, and even in fact, when I started counseling, the ACA code discouraged counselors from using computers in counseling because they were deemed unsafe, right? It wasn't a safe way to store information or, do any of that. So I went to the United Kingdom, studied, I practiced, I learned, I soaked it all up, and I came back to the US and I was so excited. I was like, look, we have to do this. And everybody's like, whatever. And that's really how the next 20 years of my life felt. No, just about 10 years, 10, 12, 15 years. So there was a lot of skepticism about using telehealth, right? And I would present and I would talk to people and they'd be like, no, it's not safe. Clients are never going to want to do that. This was the kind of message that I kept hearing. But I knew that this was going to be important. So in 2014, I launched the first virtual clinical training center through the Chicago campus, which now has served an incredible number of people and students and is still alive and well today and is running. And then when I came to William & Mary, I also started the virtual clinic here at the Flanagan Center with Dr. Becky Sheffield and Dr. SGS. Because we recognize, even before the pandemic, that it was absolutely essential that we start training our students how to use technology in the pursuit of counseling, right? Okay. Now, just by show of hands, how many of you have ever talked to a client or somebody you're working with by phone? Right? If you've talked to your client or somebody else that you're working with by phone, you're doing telehealth. That's telehealth. That's a form of telecommunication. So people were doing telehealth, but they just didn't realize it. Pamela, how can I help you?
I'm sorry, I was just raising my hand to reply to your question.
Oh, okay, good. Thanks. Appreciate your help. All right, so we are going to be talking about how telehealth, formed, the key elements of it, and we're going to talk about a big research project that actually Jerry Mize is helping with, and we're going to be talking about how to do this both ethically and legally, okay, and some of the lessons that we've learned through COVID-19. So our objectives: we want to learn the minimum and the best practices. I will try to make a distinction as we're going through, because sometimes there are things that are required by law, so that's a minimum, right? But then there are things that are a best practice, things that you want to do because it's just the best way to do it. It's the right way to do it, right? Then we're going to differentiate between some in-person services and telehealth. When is it different? When do we have to do things differently, right? Because really with telehealth, we have to do everything we're doing in-person plus some. And that's why it's a specialized skill. And that's also why it takes and requires so much training. Okay, this 6-hour training, I hope all of you will be able to attend both sections of it, is a great start. Okay, a lot of states are passing laws right now that are requiring a minimum of 6 hours of training, because that's kind of accepted as the minimum. Some have less, some have more, but for the most part, 6 is a great place to start. Okay, you're going to get a really solid overview of 6 hours. The next thing is the ethical, legal, and multicultural considerations that we have to have as we do this type of work. Most of the multicultural accessibility issues we'll be talking about in the second half. Okay, but I will hit on some as we go through them today. Next, well, there's a little bio about me. Here's my contact information. If anybody wants to contact me, happy to talk to you. I'm definitely a texter, so text works great for me. And then let's talk about the history of telehealth. So telebehavioral health has gone by many, many different names, and we'll talk about that in a second, but it's actually got a longer history than most people realize. We actually consider Carl Rogers to be the father of telebehavioral health because he did counseling by phone. He was talking to patients on the phone. He was doing supervision by phone. So he's considered not only the father of counseling, but the father of telebehavioral counseling too, which is kind of cool. And then the Nebraska Psychiatric Institute, they were one of the first larger organizations to use television and things to try to get consultations, right? So maybe they couldn't have a psychiatrist who specialized in something at their site. They could reach out to somebody who was at one of the other sites nearby, right? And they could consult, they could talk to patients, they could, connect in some way in order to be able to, provide better patient services. Massachusetts General was one of the first to conduct an operation through distance. So they had somebody on TV watching the patient and telling a doctor what to do during the procedure. Okay, kind of cool. In the 1990s, we really saw this start to pick up. We started to see more and more of it, but it was happening mostly outside the US. Okay, Germany, Australia, the UK, they were light years ahead of us. In fact, in the mid 2000s, I wrote a textbook with some of my colleagues from the UK, and we collected examples of how technology was being used in mental health all over the world. And it was amazing what was being done around the world with, avatars and virtual counseling groups and play therapy in Second Life, which is a virtual, space for people to live. So it was amazing what was happening. We were so far behind, not only in how we were using technology, but also in having guidelines and structure for knowing how to do it safely, right? And with considering our clients. In 1993, the American Telemedicine Association was created. That was really focused on medicine. I am happy to say that the ATA now is has good resources for both telebehavioral and telemedicine. One of the last presidents of ATA was actually a psychologist. So there's been some big influence about how they're serving us with, that as well. They provide a lot of really good guidelines on how to set up video conferencing, how to work with children. Like they do a lot of really good guideline tools. In 1995, the internet privatized. That was a game changer, right? When the internet became readily accessible to everybody, or almost everybody, there's still a lot of inequity, but in general, people across the society, then we started seeing much more uptick in how we were using telehealth. Then California passed the first telemedicine law in 1996. And in 2000, we said, okay, so we're not as concerned about, is telehealth good and should it be used instead of in person? But now we want to understand when and where we should be using it, right? With what population should we be using it? So we started seeing more research emerge from that. And then the federal agencies, there's two in particular that are just leaders in this field. So if you can find any of their work on telemedicine, they really are like leading the way, pioneers, and that is NASA and the Veterans Administration. Both of them are absolute leaders. For those students at William & Mary who are part of the MVC program, it is absolutely necessary you engage in telehealth. You're going to have to, right? But I would say, since the pandemic in March 2020, which we just had the anniversary, or we're having the anniversary in the next week of, the start of that for most of us, that really changed the game. Some of y'all know Dr. Skip Niles at William & Mary, and he said to me about 2 months into the pandemic, he said, I bet you have never felt so relevant in your whole professional career. Because with the pandemic, I ended up training almost 15,000 people in either telebehavioral health or online pedagogy, because so many people had to scramble to do that, right? But I was really proud of, at the Chicago School, our students didn't have to scramble. Our students and our alumni actually became leaders in the field because they already had that training, right? They were already prepared for this and they were leading the way. And so I was really excited to launch the clinic at William & Mary so that our students can. And we also implemented a requirement for all William & Mary students must have 6 hours of telehealth training prior to starting their field work. And it has to be within 6 months of starting that field work. Why is that? Because telehealth is one of the most rapidly emerging modalities in our field. It changes very quickly. I was talking to a colleague of y'all's yesterday who took counseling theories about, I think, 10, 12 years ago, right? But it was a course that they couldn't transfer into William & Mary because it was too old, right? But we were joking, not much has changed about counseling theory. So it's kind of like they're having a good smooth ride in the class because they've already taken it. But it was, not too much has changed. But if that had been telehealth, it would have been night and day. Night and day. between those two classes, right? So, all right, just some facts about that Jerry and all of us came up with in our research that we're doing. Less than 1.1% of primary care visits were via telehealth in February 2020, less than 0.1%. By March, there was a 154% increase in telehealth, 154%. By April 2020, over 40% of all primary care visits were via telehealth. 43% of health centers were capable of telemedicine prior to COVID-19, compared to 95% after COVID-19 started, right? And it's not just in the US. This has been a worldwide phenomenon. Everybody had to convert. Everybody had to make this shift. So one of the things that I think actually made me just a little bit emotional through the COVID pandemic was the amount of international collaboration that we had going on, both with research and in helping each other. When I say I trained 15,000 people, I trained 15,000 people from around the world. I had people from around the world coming to my trainings. We were talking about, regulations and legislation and guidelines that were forming all over the world. And we were trying to help each other and create resource lists and support systems. And I hope that we don't lose that as we move forward, beyond hopefully to a new normal. I hope that we can keep that international relationship going and that connection, because it really did benefit and continues to benefit our patients and our clients. All right. So you'll hear me use words a little bit interchangeably. Telehealth is kind of usually used for telemental health, but telehealth in general is like telemedicine and telemental health. Okay, so it's both of them. So it's like the umbrella term. You'll also hear me say telebehavioral health, which is actually my preferred one because I think that's a more accurate representation of what we do. But telemental health, telebehavioral health can be used interchangeably. Telemedicine is really for medical. Okay, so that's really a different field, but we have similar guidelines, similar concerns, right? There's about 38 different definitions of telehealth just in the federal regulations. Okay, that's ridiculous. That's a lot. And it's called different things, but there's just that many. There are about 8 different terms that are consistently used to describe this phenomena, but I have found as many as, I think it was 36 different terms used across the time, which means this can be difficult to do research on, right? So because you're going to do a search term, and if you're not using the right search term, it can be hard to find it. So just know that that's true. And that's why you want to really, if you do this work, stay connected with your professional associations, attend webinars, read newsletters, really stay current, because you need to see what language is being used. But as you're doing research or looking for evidence-based tools, you're going to have to look at what the literature was over time, right? It was interesting. I mean, we searched what, Jerry? We searched telemental health, telebehavioral health. I think those were the 2 major ones we searched. And we just did it for a 2-year period of 2020 to 2022. And we were getting thousands of articles just in that time period, because I mean, there's just been this explosion of research with the COVID-19 pandemic. So telebehavioral health, like I said, is really kind of my preferred, but you'll see me use telehealth, telebehavioral health, telemental health, but I'm talking about the same thing. I'm talking about providing services to individuals who are in need of mental health support. Okay, so or who are seeking support. Now, there is some, this is the actual definition through the National Institutes of Health. Telemental, that should have a health. We'll add that health right now. Sometimes you got to prove, right? Telemental health is the use of telecommunications or video conferencing technology to provide mental health services. I like the CSAT definition too, because it says it is used by skilled and knowledgeable professionals, right? I think that's an important component of it, because to do telehealth, you not only have to be skilled in mental health services, you also have to be skilled in technology. And that's where the challenge is for a lot of people. How do you do both? Because it's a lot to keep up with. All right. NADAC is a great organization, National Association for Alcohol and Drug Counselors, and they have a pretty extensive definition. And one of the things that I like about theirs is that they explain what an electronic platform is. This isn't just a phone. This is, this is anything that's transmitting information, emails, texting, chatting, cloud storage, and that it's about this interchange of information using something that's electronic. So California has a really good definition in their telemedicine law. One of the things I like to highlight about theirs is they say that it can be synchronous or real time, or it can be near real time asynchronous, which is also known as store and forward. Okay, so store and forward. We're going to talk about those terms in just a second. One of the oldest definitions of telehealth or telepractice comes from New York, and it was in 1999. But I'll tell you, I think it's still relevant, right? It's one that stood the test of time. So it really is relevant. I will say this, though. A couple of years ago, I sat in on a DBT, dialectical behavioral therapy team group with one of my colleagues who was one of my colleagues was on vacation and asked me to, run her group for her while she was gone. One of the teens knew me in the group, and they had their phones, of course. And while we're in group, in the same room, breathing the same air, she texted me. And I'm thinking, how fascinating. I used to think of telehealth as having to be this distance, right? But literally we were engaging in-person and distance counseling simultaneously, like with her texting me while we were in group, in the same room, breathing the same air. So I don't know that it has to be geographically distant. Sometimes it can happen in the same room that you're in, right? I bring up the North Carolina law because I think it's important to point out that you have to be very careful about assumptions when you're working with laws and ethics. So in North Carolina, face-to-face supervision for counselors means that as a supervisor in North Carolina, when's one of my supervisees, I can do my counseling, my supervision counseling with her via the internet. Like I can do it like this. We just have to have live synchronous communication where I can see and hear her. All right, so that has to be true. I have to be able to see and hear her. But the same state for a different discipline, social work, says that face-to-face supervision means it has to be in person, and only up to 50% of it can be virtual. So the exact same terminology, face-to-face supervision, means two totally different things in one state, right? So you have to make sure you understand, how are they defining these words, right? Don't make assumptions about what it means, okay? You have to really look at it and really understand what's meaning. So let's talk about some definitions, some key definitions. Direct to consumer. This was a big shift for COVID, and that is prior to COVID-19, a lot of the federal reimbursement programs like Medicare, Medicaid, things like that, required that we use a hub system, a spoken hub system, where I might be able to provide the level of internet security and quality, say for my private practice office, but my clients often didn't have the level of security and confidentiality that the federal government wanted. So even though I might be seeing someone, they would have to go to a clinic nearby, and they would have to be seen from that clinic instead of their home because of concerns with security, because of concerns with confidentiality. So that was a spoken hub system. That was something that basically blew up during COVID, right? Because we couldn't have people coming to clinics during the lockdowns, and because it wasn't safe. So we really shifted more to this direct to consumer model, where we are now able to see and get reimbursed fairly equitably now if we're seeing our clients at home. Okay. Now, we should educate our clients about how to make their internet more secure, things like that. And we'll talk about that as we go over some key standards. But we can see them from home if they're comfortable with it and if they are able to give informed consent about that process. Okay. Electronic health records, you also hear them called electronic medical records. These are how we store data information electronically, right? This was a huge shift. I mean, I grew up as a counselor in the age of paper products. We had thousands of paper files, right? It was a little crazy. But now everything's electronic, right? We store it. Our clients can usually access their own records. There's really cool things, but you have to look for certain things. And I'm going to give you some resources a little bit later that will teach you how to find an electronic health record that's good for you and what type of practice you're working in. Live video conferencing, or just say live telehealth. Let's just say live telehealth is synchronous, which means you can see and hear your client ideally under most laws. Some laws now, there's some exceptions, and some laws have changed that you can do telephone only. But I'm not sure that's going to last. It might, but I don't know if it will. Okay, because most people prefer that you be able to see and hear your client because of the nonverbal communication, right? Which is a big piece of it. And with synchronous, it means it's simultaneous, right? You're hearing me, you're seeing me, you could say something to me, I'd see and hear you. There's no delay. Asynchronous, or store and forward, is where I might send you an email, right? And it might sit there and wait for you to get to it. That's asynchronous communication. A chat can be both. A chat can be synchronous or asynchronous. The one thing I will say, and I'll mention this a little later too, is texting with clients is something you need to be very cautious about. It's not secure unless you're using some sort of secure chat portal. It's not something that the federal government really wants us to be doing, in the US at least. So we want to be careful about that. So I let my clients chat with me. They can text me if they need to change their appointment, which technically is PHI, but I tell them, I'm using an Apple phone, it's a secure phone. You can chat with me, but I cannot promise you that somebody else might not see it if they're standing beside me when, the notification comes up. And so I disclose those things to them and say, you're welcome to do this, but here's the limitations of this, right? I do not, however, want to have conversations about anything that's going on in your life. If you need to talk to me, you can reach out to me by chat and say, hey, do you have a few minutes to talk? And that I can do, right? I can reach out and I can respond, but I don't want them to share information that's private or confidential on that chat because it's not secure. And it's so easy to send it to the wrong person too. It's just so easy to send it to the wrong person. Originating site is the physical location of the client, which now often is the home. And we're going to talk about something called place of service when we get to documentation in the second half, where we're going to talk about how do you make a claim using telehealth and how do you code it correctly so that you are actually letting the company that's paying you back that you're doing it via telehealth. And we'll talk about place of service, which aligns with originating site. Remote patient monitoring, that's where I'm monitoring a patient at a distance, right? And I may never see the client. I may never interact with the client in person. It's something that I do from a distance, and I may be working more with a colleague to colleague for that patient than anything else. I work with an eating disorder clinic that is states away from me, states away. Right. But they will call me if they have a client who has any type of marginalized sexual identity or who might have borderline personality disorder. And I will consult with their team about how to best treat that client. Right. But that's kind of a remote monitoring. Mobile health is like mHealth. It's also your apps and things like that. And as we go through the training, I'm going to talk to you about the risk of apps and some tools that we now have to help us use apps wisely. Okay. And how to refer to them wisely. So all that's coming. All right, what about supervision? Because there's a couple of site supervisors on here. I just wanted to mention that, hey, everything we have to do for counseling, we have to do for supervision, right? And ultimately, the supervisor is the responsible party as always. So like, for example, if my supervisee is going to be showing me a recording, right? It's my responsibility to make sure that there's a signed informed consent from the client allowing for that to happen. Okay. I can't just trust my supervisee did it. I have to see it. I have to look at it. I have to review it. That has to be on there. So I need to document everything I do with my supervisees, just like I would with counseling. I have to keep that documentation. I have to store it. I have to hold on to it. So supervision, very similar to counseling in the sense that you're going to do the same type of protocols. You're going to educate your supervisee about the risk and cost and benefits of technology. So every standard that we go through just about applies to supervision as well. Okay. So let's go on down. So the study that we're working on. So I did the initial part of the study, and then Jerry Mize and Olivia Easley are helping with the best practices review. With this particular review, I looked at 7 professional ethical codes, 2 sets of guidelines, 15 regulatory board guidelines, 36 administrative codes, 35 legal statutes, 2 executive orders, 51 board websites and all of their regulations on that, 4 telehealth specific databases, and 7 academic databases. It took a while. So went through all of that to try to discern what are the best practices, right? What are the key standards that we have to have in order to engage in telehealth, both ethically and legally? The bottom line about telehealth is it has to be interdisciplinary. Right? There are other things that we can just look at our counseling books or just look at whatever discipline and we'll be okay. You know, it'll be all right. But with telehealth, there is no professional code. There's no law that addresses everything that we need to know. That might happen one day, but it's not in existence as far as I can tell in this current state. Okay. So when I talk about ethical decision-making with telehealth, I use 3 codes. Okay, I don't just use one. I use 3 different ethical codes to be able to discern how I am going to make a decision about something, right? I use the ACA code, I use the NBCC code, I use the NADAC code because I think they're really good codes. NADAC has a really strong code for telehealth. So I look at all 3 of those to be able to make decisions about what I need to do. Okay. Out of this study that we're doing, we came up with 14 key standards. And these are the key standards that the rest of the training is going to be based on. The first one is scope of practice. What's your legal ability to do and what can you do, right? What and under what guidelines do you do it? Disclosures. Disclosures are the information that we tell our clients so that they can give us informed consent. Okay, so they're 2 different words. I see them used interchangeably, but they really mean 2 different things. Okay, disclosure is what I tell you so that you can give me informed consent. Right, so that's the difference there. Counseling relationship and boundaries. Obviously, it can get a little fuzzy when you're online, right? People might feel like there's not as clear boundaries, and we talk about what those are and how to set those. Client verification. You have to verify who your client is. You're supposed to do that in person too, right? Especially if they're using any type of payment, you know, third-party payer. You need to verify that the person in front of you is the person that, you know, you're billing, you know, that they say they're who they are. Confidentiality, there's a lot of ins and nitty-gritties about confidentiality in technology and how to protect that in some ways that you might not even thought might give up somebody's confidentiality, right? And we're responsible for protecting current and future confidentiality, which I'll explain when we get into that. Standards of care, best practices. How do we know what those are? Where do we find that information? Appropriate intake and screening. Not everybody is an appropriate fit for telehealth, okay? And so we'll talk about that and how do we determine that? Documentation. How do we document? Where do we document? What should be documented? What shouldn't be documented? We're going to talk about all that. Virtual presence, your presence online. What do you have to disclose? To whom? Where? How? All of that. Because there's a lot of rules about, like, if you have a website, what has to be on it if you're a counselor, right? You have to have certain pieces of information that the federal government requires. Your state may have certain requirements. How do you know what those are and what should you do and how should you do it? Maintaining ongoing training and competence. Very rapidly emerging field. This is considered a modality of counseling, and it is fast moving. All right, so fast that I consider myself to be, you know, a telehealth expert, but I spend at least an hour a week on telehealth. usually more because I'm also doing this research project and stuff. But I mean, every Wednesday, I try to dedicate my lunch to telehealth every Wednesday. Okay. So, it takes up a lot of time to stay current. Current technology. What's the current technology? What's the current encryption rules? How do I know what I should be doing? And where would I find that information? And how would I know if it changed? Professionalism. Yeah, professionalism. I've had, as the ethics chair in North Carolina and working on the ACA ethics panel, I've had some interesting encounters with some social media conflicts, with ethical conflicts. I'll tell you some stories, some things that people have done to each other as professionals even. And then last but not least, diversity, right? Accessibility, multiculturalism. We're going to look at that as, I'm actually changing the title of that section to diversity, equity, and inclusion, because I think it's a more accurate representation of what I'm trying to get through that one. Okay. So these are the 14 areas that you're going to know about by the time we finish this training. All right. Any questions at this point? So I can take a sip of my tea. And does anybody need the handout? I know that Tammy and them have been doing a great job of getting that out, but if you need the handout, just ask in the chat and they'll repost the link. Go ahead, Tammy.
Yeah, so the question I have is in terms of the cloud. Is that something that you have control over in terms of things getting there? Or because, my concern is like for our schoolwork, like there's a cloud, things get saved to that. But if I'm doing, let's say I'm in my practicum or internship and I'm doing a recording for it, does it automatically get saved to the cloud, or do I have control over where that goes?
Right. And Dr. SGS and Jerry, correct me if I'm wrong, I believe y'all get some training on that initially about storing that. So there's supposed to be guidelines that show you how to store from Zoom. And plus you also get a HIPAA compliant Zoom account. So your Zoom account changes when you move into field work. And the reason being because it has a higher level of security, and it's supposed to map. When you record, it's supposed to be mapping to OneDrive. We did have a glitch with that we caught, where some people were saving it to their computer and then uploading, which kind of defeats the purpose of what we were doing. So it's supposed to map straight from that HIPAA compliant Zoom to your OneDrive. And in that, what happens, OneDrive is a Microsoft product, right? So it's part of the Microsoft 365 account. And that is HIPAA compliant, which I'm putting in quotes. We'll talk about that in a few minutes. It's also FERPA compliant. So it's a secure encrypted portal. It's kind of like when we used to have paper products, paper files and stuff, we had what was called the double lock system. You had to have 2 locks on your system, right? You had to lock the door and you had to lock your file cabinet. That was your double lock system. In technology, it's very much the same way. You should be logging into your computer with a password, and you should be logging into Microsoft Office, you have to, with a password, right? So that's your double lock system. So it's very secure. Cloud computing is actually more secure than any other system we've ever had. It's a beautiful system because think of it this way, if I have a file cabinet, right? And I buy a file cabinet as a private practitioner, let's face it, I'm not going to be able to buy the fireproof file cabinet. Okay. Those things are stupid expensive. So, but I can buy a regular, maybe 2-drawer file cabinet. That's not going to strain my budget. Right. But if Pedro and Melanie and Darlene and Tracy and Anne Marie and I all get together and we pool our money, we can buy like the file cabinet that I tell it what file I want and it pulls it out for me, so it's like going to be like really snazzy and have lots of security, and it's going to be fireproof, and nobody's going to be able to get in that thing if they don't know how to, right? So cloud computing is that idea of resource pooling, right? We're all pooling our resources so we can have a better product. I can tell you a real quick story that kind of proves the importance of cloud. Many of you, I'm sure, have used Dropbox, right? Dropbox has warehouses with servers literally all over the world. Okay, like literally. And so their warehouse in Tennessee caught fire a few years ago, and they lost about 50 of their servers in that fire. but not a single piece of data was lost. Because the second that the fire suppression system went into place, it transferred all that data to other locations. So not a single piece of data was lost, right? So that's the power of cloud. It's very secure. You can get the highest level of security. It's encrypted, usually at 256 encryption, which is right now not the highest level of encryption, but it's the highest like publicly accessible encryption. And so that you can, get, I would say 256 is the most easily accessible, publicly accessible encryption. There's higher levels of encryption, but so you get all of those benefits of cloud computing when you're doing that. Does that help, Tammy?
Yes, thank you very much.
Yeah. Okay. All right, great. Let's go into this. Y'all ready? Straps up, put your seatbelts on. Gets really fast. Okay, here we go. So ethics versus law. Ethics are rules from our guidelines from our professional associations, right? There are things that we should be aspiring to, and there's some that are mandatory, right? I should aspire to do no harm. That's hard to measure though. How can I prove I did no harm? Mandatory, don't sleep with your clients. Why do I have to say that all the time? Okay, don't sleep with your clients. That's a mandatory ethical code, right? Ethics tend to be reactive and proactive. I had the sheer honor of working on the cyber committee that helped write the H section of the current ACA code. And it was amazing to be in that process, right? To be working with, I think there was like 8 of us on the committee and hashing through issues and talking about what we wanted in the code and what couldn't be in the code. And there's so many politics. Like we really wanted to include in the section H, we wanted to include some guidelines about telesupervision and about how to appropriate do supervision. We got so much pushback on that politically. People did not want that in the code, right? So there's some politics that happened with that, okay? Could Jerry or Kimmy throw up the handouts again in the chat for me? Then the laws come from our government, right? So governments make laws. Now, does this mean that laws are like perfect and, are done with, in isolation? No, they have morals, they have politics, they have context of when they were passed, right? All of those things influence laws. So laws aren't always fair. They're not always equitable. They're not always reasonable. Okay. But when we have a law, we have to follow that law. Our code of ethics even says you have to follow the law. So you have an ethical and legal obligation to follow the law. Now, if you disagree with the law, as a social justice advocate, you need to try to make change, right? And even ACA says that if you don't like something, you need to change it. You need to work on changing it. So we may not always like the laws, but we do have to follow the laws, and we have to elicit change where we can, when we can. Okay, so we have those obligations. If I break an ethical code, I might get my name in a newsletter. I might lose a credential. I might get a slap on the hand. I might get a reprimand, but they can't take my license, okay? Because they don't have that power. Professional associations don't. However, professional associations will and can tell our licensure boards when we get in trouble with them. And the licensure boards do take that into consideration about how that might impact your licensure. Okay, so if you get in trouble one, you could get in trouble with all. If I break the law, I can go to jail, I can get fined, I can lose my license. I will say this though, well, I served on the North Carolina Licensure Board and I learned a lot in that process. Most licensure boards do not want to take people's licenses. They want you to stay licensed because the only way that they can regulate you is if you have a license. If you don't have a license, they can't regulate you. Right? So they do want to try to keep people licensed as well. Jerry, somebody just came in the room. So if you and Tammy, one of y'all can pop that thing back up in there for me. Thank you. So this is
Dr. LA. Is that related to why? Because so we have this assignment in our contemporary issues class where we go and look through like different licensure and ethical violations that are posted. And I was really surprised to see how often there was like a probation or a reinstatement.
Right.
Even with some of these things that are fairly egregious at times, not like just a social media like connection, like more substantive. And so I guess, yeah,
That's why, because they'd rather remediate than eliminate.
got it.
In the time that I was on the North Carolina licensure board for 6 years, and in that 6-year period, we only took 3 licenses. And we had a lot of complaints. There was a lot of complaints. I mean, we had over 4,000 licensees. So that was a lot of potential for complaints. One person had an affair with his client and murdered and then burned down his own building to cover it up. That was pretty egregious, right? One person ran a home for boys and had horrific sexual abuse in the home. And one person had 18.3, it was $18.3 million worth of Medicaid fraud. Now, here's a tip for everybody. If you ever make $1 million doing counseling, you're doing something illegal. Okay, can we just all agree on that? Because this is not a profession where you're supposed to be making a ton of money. Okay, so, but that person was billing, was very creative, had a counselor die and kept billing. That counselor was providing services post-death, and a few other people that she had made up. So, those are pretty extreme cases, but usually every other case was remediation of some sort. Okay, and we'll talk about a few of those cases, which are all public knowledge now. So, all right, some states, the ethic code is also law. Like in North Carolina, the ACA code is law. It's actually codified. It's codified in the law. So when you have an ethical violation, you can also be found to be legally negligent. Okay, so you have to understand how that works in your state. Ethics is a continuous process. It is not an event. And we're going to talk later about ethical decision-making models. If you don't have one, you really need to have one. My ethical decision-making model has saved me in so many cases. Okay, I use Wellful, and I literally have it, and I really literally I go through and I write it out and I put it in the person's file, right? So I write out my ethical decision-making model. Whenever anything icky comes up, I'm going to do that response, right? I'm going to fill that out, get consultation. It's not if you make mistakes in counseling, it's when you make mistakes in counseling. And there's a play therapy adage that I really love to use when it comes to ethics, and that is, it's not what you did, it's what you do with what you did that matters. And I have seen that play out over and over in ethical cases that I've worked or consulted on. How a person responds to a mistake, first of all, I think says a lot about your integrity, right? And 2, it will determine the outcome. It will determine how you are punished or not punished, remediated, not remediated, all of that. So it's not that you made a mistake, it's what you do with the mistake that matters. Okay, I mean, we want to try to avoid mistakes as much as we can, because ultimately our primary initiative is to do no harm, right? Y'all may hear my cat. He's just sitting here beside me screaming. I apologize. So it's not what you do, it's what you do with what you did that matters. And we'll hear some examples of that and how that played out, especially with HIPAA breaches. Okay. All right. These are all the codes that are in the field of the helping field right now that I use to guide my work with telehealth. Okay, and I literally just updated these last night. NADAC has a brand new code. The social workers have a new code, and the national board has a fairly new policy that they've implemented. So these are pretty current. I checked them all last night, so I'm pretty sure I got all the current ones. And so these are all of the codes that we have to look at. And in the second half of this training, I'm going to give you a sheet that's going to break out each one of these standards and show you what each code says about those standards. Okay, usually it would have been in the handouts, but because last night I realized NADAC had snuck in a new code on me and I hadn't had time to update it, I'm going to have to update that between part 1 and part 2, but I'll make sure you get that handout when we get to part 2. Okay, and so you can see what each of these codes says about each of the 14 standards. Okay, and not all of them have something on all the standards, but they have something to say about a lot of them. So my background, actually, my undergrad is pre-law, and I love pre-law. I've actually did a paralegal certificate just for fun. So I love the law, and I had the pleasure an honor of working at the House of Representatives for several years and working on several pieces of major legislation like the American Disabilities Act, the pregnancy law, family medical leave. Those were wonderful experiences to really get to understand how legislation is created and how it's implemented. But in the United States, at least, I know not everybody's from the United States, but in the United States, we're a federalized system. So that means that we have federal law, state law, and case law being law that comes out of our court decisions, okay? An example of case law that you're probably all familiar with is Tarasoff, right? But Tarasoff came out of a specific federal region, and it applies to not every state. Not every state has adopted Tarasoff. Okay, so like in North Carolina, we have to follow Gregory and Kilbride, which is a totally different case law that applies to how we handle people who might be a harm to themselves or others. Okay, it's not a Tarasoff. But when you're taking those national tests like the NCE and the NCMHCE, you're going to think Tarasoff, because that in general is the national norm for how we handle at-risk behavior. Okay, so the problem is, federal law typically is the one that we should fall to, right? Like HIPAA. HIPAA is an example of a federal law. But then here comes Florida with their special privacy law that's more stringent than HIPAA. So if I'm in Florida, I have to know that, and I have to know that that law requires more stringent requirements than HIPAA, so it actually supersedes it. Okay? And if I'm in an area where there's been a case decision and a case law, that might supersede both of them. So it's not like clean, okay? It's like you have to stay current. Could you possibly monitor all the court dockets? Absolutely not. Can you monitor all the federal laws? Yes, but not unless you want to have a part-time job just doing that. So what you have to do is you have to log into things there like blogs, newsletters, go to webinars and trainings, connect with the national system of resource technical centers that I'm going to tell you about. So I'm going to give you lots of ways to stay current, but you're not expected to be able to do this on your own. You have to rely on other people and other associations and work together to be able to stay current. Okay, it's just impossible to do it on your own. Even I can. Now, if the law doesn't tell me what to do, I have to go to my code of ethics. So I go to law first, then I go to code of ethics. Code of ethics, I'm going to start with the ones that I'm a member of: ACA, NADAC, APA, NBC. So those four, I belong to all four of those organizations as a member. Okay. Now, the problem is that sometimes they conflict with each other. So I have to kind of designate one to be my primary identity. And for me, that's ACA. ACA is my primary identity. And the other three to me are really kind of advisatory, like advising, right? But because I have an NCC, I have an ACS, and I have a board certified telemental health provider credential, I have to pay attention to NBCC. I can't violate any of that because I have so many credentials with them, right? I have to pay attention to them. So I'd say ACA, NBCC, NADAC, and then APA. That would be the order that I would use it based off my identity as a counselor and the certifications that I have. So outside of that, let's say I can't find the answer to something. Then I can go to other organizations like the social work, the marriage and family. I can look to other helping professions. Now, I also work in Canada. I love working in Canada. And so I also look to the Canadian associations, right? I look to them for some guidance. Now they're a little bit of a Wild West up there sometimes, but it's like, there's still guidance up there that could be helpful. So I'll look to them. And also they're right next door to us. So it makes sense that I would reach out to Canada before, say, I would reach out to India. Okay. So, and we have a similar system in a lot of ways. So I can reach out to my ethics, related ethics. I can look at within the United States, outside the United States. I can also then look at my journals, right? My peer-reviewed articles, my peer-reviewed presentations, things like that, where I know the information has been vetted. Like, for example, I frequently attend webinars and seminars through the Telehealth Certification Institute. It's one of my favorites. And it's reliably awesome information. Like, they do a great job of vetting the information that they have. I have been to some presentations where I'm like, oh my, and they're telling it, I'm like, I have to speak up and be like, okay, sorry, I need to correct that. We cannot use Skype for telehealth. Sorry. And so you have to sometimes also advocate for correct information. But if I can't find best practices within the counseling field, I can look to psychology, to social work, to marriage and family, to drug and alcohol, I can look to all my, cousins and brothers and sisters in the mental health field. So I can look to a wide variety, and I'm actually going to be a better counselor for that when I use a variety of resources to support what I'm doing. Okay. All right, so let's jump into HIPAA, and we'll go a little while and then we'll take a break. HIPAA. All right, first of all, one of my biggest pet peeves as a professor is it's HIPAA. It is not HIPPA. Okay, so if you don't leave with anything else, try to leave with that. All right, so it is the Health Information Protection and Accountability Act. So 2 A's, not 2 P's. And it gets updated regularly. Right? I mean, it started many moons ago. It was 20 years ago. Well, 25 years ago. And so we have the security rule, the privacy rule, the breach notification rule, and then what we call the omnibus rule. And it is actually under review right now. And so there are changes that are under review. I kept holding out. That's why I delayed the training, because I wanted to have the new HIPAA rules, and they keep putting them off. So I had to finally just bite the bullet, and we're going to do it. And when they do come out with a HIPAA, I'll do an update. And if I have your email on this Zoom, I will make sure you get a copy of that update, because I'm expecting it any day. So when we get that update, I will share that. Now, when COVID came out, and this is not current regulation, so I want to stress this is archive regulation. When COVID started, I'll save my politics. So hold on, let me adjust what I'm about to say. Okay, so the person that was in charge of the Health and Human Services said, oh no, it's an emergency. We're just not going to use HIPAA. Like, you're not going to be fined if you do things against HIPAA. As a telehealth provider, I was over here going, what are you doing? And freaking out. And so a couple of people posted this announcement on our counselor education listserv, which is a big listserv. And I immediately got to work, and I was like, and I wrote up this whole big thing. It was about that long. And I was like, hello, before everybody jumps on using Skype, I'd like to point out that HHS does not relieve us of our requirements under our code of ethics. It does not relieve us under our state laws. It does not, like, hold the horses, people. Do not leave the station, okay? You cannot ignore HIPAA because you have all these other requirements that you have to follow. Let's not abandon HIPAA and do harm to our clients. HIPAA is there to protect our clients. It's also there to protect us. Okay, so like, just because one person says, oh, you don't have to do this, there's a whole lot of other people saying you do. Okay, so I had to really bring that to attention. And it was kind of interesting because I sent that email back out, and I'm like, stop, you can't just do this. And the director of ACA wrote me like within 2 minutes, and he was like, thank you so much. We were working on something and you beat us to it. I was like, we can't do this, so we always have a responsibility to treat our clients' information with confidentiality and to use best practices. Don't ever abandon that. Okay. The few times that I feel like I've had to abandon some level of that have been in emergency situations where, say, one time I was in California and one of my clients called me and she said, I don't feel safe. I'm having visions of the kids and I sitting on the railroad track and I don't know what to do, right? And so in that situation, I'm in California. She's in North Carolina right at the time. And I can't commit her because I'm in California, right? And you have to appear before the magistrate. Thank goodness I had a relationship with the sheriff. And I reached out to the sheriff and I was like, Steve, I need one of your guys to go now to get some help to this person. Like now, I need somebody there now, right? And because we had a pre-existing relationship, he took me seriously and he went. In that situation, I felt like it was more important that I violate that client's confidentiality and get her the support she needed than it was to protect that. So again, ethical decision-making model though, right? I had to look at my ethical decision-making model to determine if that's what I needed to do and document it. And it worked out and everybody was safe. So just because something's said, I want you to really just, yes, there is, Leo, it's Pipeda. It's P-I-P-E-D-A. That's the Canadian version, P-I-P-E-D-A. And I can get you some information on that too. If you email me, I can get you some because I've done some trainings there too. So just because it's said by one person doesn't mean it's true. Check it out. Be a critical consumer of the regulations, of the laws, of information you see on the internet, information you hear in the presentation. That's all what I'm saying that for. Okay. So the main component of HIPAA that we deal with is the HIPAA Title II, known as the Administrative Simplification. That's a funny one. That's an oxymoron, simplification provision. Okay. So it's definitely an oxymoron. So I've got some extra links here for you and some YouTubes, but I'm just going to walk you through it. Basically, HIPAA created a few major things that now are part of our lives. Okay. National Provider Identification Number in the United States. The NPI is a 10-digit number that you will sign up for, and that will become your Social Security number as a mental health provider. Okay, it is your number. It will be your number for life. It will be forever assigned to you. You don't lose it. Okay, so your MPI is yours. All right, the second thing is transaction and code set privacy standards. So it set a protocol for how we were going to transmit electronic data. Okay, because before this, it was a free-for-all. Like everybody had their own system, different hackers were hacking into it. It was crazy, right? You couldn't really be sure things were secure. So this set some standards for what was expected and how we were going to translate and transmit information. The privacy rule, and then also the security rule. And then it was funny, they passed the privacy rule and the security rule, and they're like, oh, everybody's going to want to do this. It's such a great idea. It's going to help our clients, it's going to help us. You know, everybody's going to be on board. And some people were like, I'm not doing all that. Like, why would I do all that? Because they had a lot of bark, but no bite. Right. So years later, they had to pass high tech, which is the enforcement rule, because then they had to implement fines and ways that people could get in trouble. There is potentially jail time for HIPAA violations now. Okay, but that wasn't the case when it first came out. All right, HIPAA compliance. And I'm going to use HIPAA compliance in quotes here. There is no such thing as HIPAA compliance. Like there's no way to get certified, although some companies want to tell you that, as being HIPAA compliant. Okay, there's no federal certification. Oh, you're HIPAA compliant. HIPAA compliance is like ethical decision-making. It is a process. It is not an event. Okay, and it requires 3 components. You have to have physical, administrative, and technical safeguards in place. And not all of that is contingent on one person. Okay. Before I go any further, I do want to mention HIPAA is scalable. When we say that a law is scalable, it means that based off the type of institution, organization, or private practice you have more or less responsibilities under the law. Okay, and I'll explain what I mean in a second. Physical. As a sole practitioner, okay, as an individual practitioner, I have the responsibility of using a secure internet when I am working with my clients. Okay, I have to have the right equipment. I have to have an up-to-date modem. I have to have the right wires. I have to have secure Wi-Fi, like the equipment for the Wi-Fi. I have to have the physical means of providing a confidential and encrypted space. Okay, so that's the physical piece of it. So for example, we used to use Skype. Skype was long ago, right? I don't even know if Skype's still around, but Skype would use technology where it would literally, if Liz was sending me a Skype message, right? And she was near Tracy and Talia and Chris, it would literally bounce from Liz's computer to Talia's, to Tracy's, to Chris's, to mine. So it's literally using our computers to bounce the message. That's not very confidential. right? I literally years ago when I was at a conference, I conference called one of my kids at home using Skype, and somebody else was in the Skype message with us having their own conversation with somebody else because the information had crossed. So not very secure, right? Now we used to have Skype Business, which I think now is Teams, but Skype Business to Skype Business, if both people had Skype Business, that used the network. So that was more secure, but both people had to be using a business account, okay, to have that security. So you have to have the physical capability of having a secure connection. Administratively, I have to set policies and rules and have training and things like that, and have procedures and policies that you sign off on. That's the administrative part. I also have to track when I disclose information, how I use your information, and you have the right to ask for an accounting of that. Okay, so that's part of the administrative. The technical is using the right type of Wi-Fi, using the right type of internet. Like for example, it would be absolutely not HIPAA compliant to talk to a client using an airport Wi-Fi. That is an unsecure Wi-Fi. There's nothing secure about it, right? That would be inappropriate. And when I do my client work, I am hardwired in. Okay, I use something called a power line adapter, which plugs into the outlet under my desk here. And there's another one downstairs by my modem. And then the CAT cable, the network cable, is plugged into those, and it uses the electrical system in my house as if it were hardwired in. It's a very cool system. All right, it's called power line adapters. And those power line adapters allow me to have a secure connection with my client that nobody else can, you know, intervene through it being in the Wi-Fi. It also gives me a better connection. So technically it helps me have a better connection with my clients and with my students. Okay, so I have these technical guidelines that I have to follow. So I have to have physical, network, and a physical, technical, and administrative. The part where other people come in is I have to get information from my network provider, from my computer people, from not so much my telephone company, but like my tech guy when he comes in, like all of this, I have to have rules, I have to have contracts, I have to know that if I'm using my iPhone, right, for work, and there's a breach, which Apple says will never happen, but if there's a breach, right, and I have to know that Apple is going to tell people about the breach, right? What is your procedure for telling about that breach? That's part of the administrative process, okay? So I'm depending on other people too to do their part. So I can't be HIPAA compliant on my own, right? Because I'm depending on all these other companies to also do their part, which is where business associate contracts come in. And we'll talk about those in a second, okay? So any company that uses PHI, which is protected health information, has to follow HIPAA, okay? So any company that transmits PHI for the purpose of billing especially will have to follow HIPAA. Everybody should follow HIPAA because HIPAA makes it safe for us to communicate with one another, okay? I'm a HIPAA fan. All right, so what is PHI? What is all this information that we're trying to protect, right? Well, there's 18 categories, and I want you to take a look at these 18 categories. Well, take a seat. Is anybody surprised by any of the things that we have to protect? And Leo, just so you know, it's very similar in Canada, very similar. I think when I first came on, I was a little surprised. Yeah, Jerry, device IDs, right? So the serial or device, because you can use that to map IP addresses. Good, Susan. Yep. So an IP address is just like a mailing address. An IP address is the address of your device, right? So it's like I can locate you through your device ID. I can locate you through your IP address. I can locate you. If I can locate you, if I can connect to you using that, right, then that's a problem. That's something I have to protect. And Diana put in a chat to me about how private school or public schools were not prepared for this when it came out. She was absolutely right. And I'm actually going to show you a resource that talks about how FERPA and HIPAA come together, right? And there's a really good resource page that talks about that I'm going to share. Okay. Yeah. So let me give you an example, Susan. So let's say that I want to do a program evaluation with my clients, right? Which I love doing evaluation. I want to see if I'm doing a good job. It's part of our ethical obligations to see and evaluate our effectiveness, right? I want to use SurveyMonkey. Well, SurveyMonkey automatically collects the IP address, right? Well, I have to turn that off if I'm going to do a program or I have to find a way to protect it. And I have to disclose to the clients, yes, this is a confidential survey, but I can't say it's an anonymous survey, right? So that's the piece there. So IP addresses are really tricky in that way, okay? The other one is biometrics, your fingerprint, your eye, anything that's a physical characteristic of you. I love this one. Any other unique identifying number, characteristic, or code. That's like the, all other jobs, duties as assigned, that's at the end of your job description, right? Yeah, it's the same thing. So this is, means that if there's any characteristic that I could use to backtrack to who this person was, I have to protect it. And it's called de-identifying the information. So if I disclose something, I have to de-identify any of these items unless I have permission from the client, written authorization from the client to disclose them. There are some exceptions, but for the most part, I have to have written disclosure to be able to share any of this information. Okay. Yes, that is exactly right, Susan. A student ID is considered that, right? So student ID number, student ID card, any of those things can be used to track back to the person. Now, another one that's interesting to me is the geographic identifier. Do y'all see that I have less than state? So anything that is less than the state is considered a personal identifying. So zip code, street address, city. The thought being that if it's less than state, I might be able to track it back to the person. Okay. So again, it's not that you don't use these, you just have to have written authorization to share this information. So when you disclose information to someone, you only want to provide them with the information they need. Like if I'm doing a consult with another clinician, that clinician does not need to know that person's telephone number. That person does not need to know their social security number, right? I'm only going to provide the information I need to get the consult. So I'm not going to give extraneous information. Okay. And here's a resource for this right here. Right. The other one that I think is a big one that people don't think about are URLs, like website addresses and things like that. That's another big one. Okay. So this is information we have to protect. And we're going to watch a video about HIPAA and then we'll take our break. Okay. So let's do that. Let me find it. Oh, I have to stop sharing for a second because I got to share my sound and find my video. I had it. Where did it go? There it is. Okay. All right.
What is HIPAA compliance? The Health Insurance Portability and Accountability Act, or HIPAA, was created to uphold the integrity of protected health information. It's regulated by the U.S. Department of Health and Human Services and carries hefty fines for violations. Compliance is the adherence to physical.
Let's try it again. Didn't it do it? Let's see. Share.
It was showing a different window.
Ah, that's tricky. Yeah. Now let's try it.
What is HIPAA compliance? The Health Insurance Portability and Accountability Act, or HIPAA, was created to uphold the integrity of protected health information. It's regulated by the U.S. Department of Health and Human Services and carries hefty fines for violations. Compliance is the adherence to physical, administrative, and technical safeguards of HIPAA. We have put together this checklist to explain how to comply with HIPAA. Implement technical safeguards. These include network encryption of protected health information to NIST cryptographic standards, multi-factor authentication to secure and control access to healthcare IT systems, measures to ensure the integrity of EPHI, such as protecting against unauthorized changes, device encryption for mobile devices and laptops, intelligent audit controls, automatic log-off parameters and password strength requirements. Implement physical safeguards. These include controlled physical access to the facility, managed workstations and limiting which workstations can access health data, protecting mobile devices with a policy that removes data before a mobile device is circulated to another user, and ensure that mobile devices can be remotely wiped if lost or stolen, tracking servers and inventorying all digital infrastructure, data destruction protocols for all retired or repurposed hardware. Implement administrative safeguards. These include a comprehensive risk assessment for all health data, regular systematic risk management, including sanctions for non-compliant employees, EPHI staff training, building contingencies with a preparation process that keeps data safe and available, contingency testing to ensure your processes will work when you need them the most, blocking unauthorized access, including parties such as unauthorized subcontractors or parent companies from viewing EPHI, documenting all security incidents and report to authorities when required. Next on the checklist is the HIPAA privacy rule, which ensures that protected health information is never disclosed. The rule stipulates a prompt response to patient access requests within 30 days, notice of privacy practices, privacy training for staff. The patient must provide authority for any redacted EPHI use. HIPAA's breach notification rule explains who to notify in the event of a data breach. Know the notification process. Make both your patients and the HHS department aware of any breach within 60 days. Notify the media if over 500 individuals' records are compromised. Check twice for 4. A breach notification message must contain these 4 elements: a description of the EPHI and personal identifiers involved in the breach, who gained unauthorized access to PHI or related information, whether PHI details were simply seen or whether any PHI was taken, the degree to which risk mitigation has succeeded. The HIPAA Final Omnibus Rule sets out additional requirements for covered entities and business associates affected by HIPAA. These requirements state that covered entities and business associates must refresh business associate agreements to reflect the Omnibus Rule changes, get new signed BAA copies that include the Omnibus information to stay compliant, refresh privacy policies to reflect Omnibus changes, update the Notice of Privacy Practices, finalize training to include all Omnibus Rule adjustments. Atlantic.net can assist you with your HIPAA compliance needs that
Okay, so I think that was a really good overview. Let's take a 10-minute break. We'll come back and I'll hit some highlights and re-emphasize, because a lot of what they went over I have in the notes for you, but I want to just highlight a few areas. I'll see you in about 10 minutes. Okay. All right. I think some of you are near me. The wind is really picking up here, so I'm hoping my internet is going to hold out. But we're about to, I think it's supposed to start snowing.
We have snow already, Dr. Elliott. It's snowing in Maryland,
Yeah.
Southern Maryland.
We have a team in Northern Virginia.
I feel
It is-
betrayed. No.
It's crazy. It looks like a blizzard outside.
Yeah. It's
Yes.
supposed to start here. My poor cherry tree out back is in this beautiful blossoms, and I'm like, it's going to be 22 tonight.
I'm
Yeah.
so happy to be able to share with all of you.
Thank you, Casey. We so appreciate you sending
It's
the weather.
beautiful out here. It's colder than heck. It's below 0, but it's not snowing.
She sent it from up north to us.
Only because I love you.
Oh, so, but just know if my internet does cut out, I will reconnect with my phone as quickly as I can. But it is getting really windy, so I'm a little nervous, but it should be okay. The worst of it's supposed to be this afternoon. So
Tracy, love us a little bit less next time, okay?
yeah, Tracy, exactly. All right. Welcome back, everybody. I hope this is really helpful. Please remember, ask questions, wonder about things. I'm going to drop in at the end of the session. If you could fill out this evaluation, then you will get a certificate for the first half. One thing about the certificates is we run a whole webinar series. So like the whole spring, we have several webinars that are happening. I find it easier just to do all the certificates at the end of the webinar series. So no, you'll get those at the end of spring, so probably early May. Okay, and I'll just sit down and do it in one fell swoop, and they'll come out to you and they'll be in your email. So I would definitely say by the end of May, if you didn't see it, you should check your junk folder or your spam folder. It's probably in there. Okay, but you always can reach out to me too if you don't get it. Okay, and sometimes students ask me, why would I need this certificate? Take the certificate because, well, for our students, y'all need it for your field work. But the other thing is that this is creating your scope of practice, right? This is creating what you're able to do and what you're trained to do. And you should keep copies of your certificates. And I also encourage you to keep a spreadsheet showing all the certificates, when you earned it, who did the training, and then like, did it cover ethics? Did it cover supervision? What did it cover? Like a core area. But I have a spreadsheet that dates all the way back to 1992. And so I have all the certificates that I've ever earned, which are a lot. So I really strongly encourage you to do that. Okay, let's keep talking about HIPAA. All right, so I'm gonna share my screen again. Show the right one. There we go. All right, so the privacy rule. So the privacy rule is what we need to protect of our clients and what we're going to tell them about how we're going to protect that. Okay, it's all about the uses and disclosures of that PHI we talked about, the protected health information. I'm not going to go over this in full detail because I think the video does a really good job of overview, but I want to hit some highlights here. So there's really two pieces to this. There's the notice that you have these rights, right? And then there's the Bill of Rights, which is part of that says these are your rights, right? So you have rights, you have the right to ask questions, you have the right to file complaints, you have the right to ask for an accounting, and here are your rights, okay? The notice of privacy policies has to be posted in a prominent area if you have a physical location. It has to be in plain language. All right. And if you have a website, it needs to be posted in a prominent location and it needs to use plain language. So you can't hide it, right? It needs to be visible. It needs to be front and center kind of thing. You do not have to give everybody a copy, but you do need to try to give them a copy. Okay. So for sometimes you might notice when you go to the doctor, they say, here, I'm going to let you read this and then just sign that you received it. Right. And do you want a copy of it? And I always say, no, I teach HIPAA. I don't need a copy of it. Right. But if you want a copy, you can have a copy. You're allowed to request that electronically or a physical copy. All right. So these are the Bill of Rights. You can request restrictions. You can receive confidential communications. One of the things I really stress to counselors is that when you're creating your intake form, you have to ask if you can leave a message at the phone or not. You have to ask if you can send an email or not. If you want to do text, you have to say, may I send a text, yes or no, right? You can't just collect the information and assume that's, authorization. It's not. They have to literally check, yes, you can leave a message. Yes, you can send a text. Yes, you can do an email. That's what it means by receive confidential communications. Go ahead, Jerry.
Excuse me. So in that regard, this brings up a small ethical scenario where what if there's an event where your client, maybe there's a crisis, or maybe an example for me I could think of might be if it's like an elderly client who when they didn't show up to session and you know that they are perhaps a fall risk.
Mm-hmm.
So
that's when you have an emergency contact, right? And you've agreed with the client that if I can't reach you, may I call this person?
Mm-hmm. Okay.
Yeah. Mm-hmm. And I wouldn't say anything other than if, let's say Darlene's my client, right? And she gave me permission to call Ashlyn, right? Then I would just call Ashlyn and say, hey, Ashlyn, I'm worried about your mom. Have you heard from her today? That's all I would say. Okay. Yeah, and I have had to call one of my clients recently because I couldn't reach him, but he and I had that pre-agreed that if I couldn't reach him, I could call his daughter. And so I called his daughter and she was able to find him and connect with him, and we were able to reconnect. But I mean, it's nice to have that backup. Okay. CJ, I think you had a question. What was your question?
Oh, I just, whoops. Sorry, I have to move to a phone call. So I was asking if I did have a question, if I can just unmute on the phone.
Oh, yeah, absolutely. Okay. All right. And then Leo, I didn't quite understand your question. Can you ask it again?
Yeah, with the DSM, it's ancient. Are they doing a new one, and is it close to HIPAA at all?
Well, HIPAA is about the disclosure of the diagnosis, but the DSM-5 TR is coming out this month. So the new edition is coming out this month, but it's more about disclosing diagnosis that would be prohibited under HIPAA without authorization. You can't disclose that. Now, there are some exceptions. If you have given me permission to bill your insurance, I have to disclose that diagnosis, right? So that would be an example of an exception that's it should be stated in there in your informed consent, in your notice of privacy, that, you know, if you decide to use insurance, I will have to disclose this diagnosis. And even in the informed consent, I think in the disclosure, I say also, please know that in order to be paid by third parties, often I'm required to give a diagnosis, which not everybody wants to, right? So then they have to make a decision, an informed decision about, do I have you bill my insurance or do I pay out of pocket? Okay, good. All right, so administrative requirements, like I said, you need to have that notice. They need to have it by the first day of service. Electronic or physical. And if they ask for it electronic, they can then follow up and ask for a physical. Doesn't matter, you have to give it to them. And then written documentation that they acknowledge it. So they just acknowledge it. They don't have to sign the notice. They just need to acknowledge that they received it. Okay, so that could be an email back. Thank you for the notice. In the company that I'm working with right now, it's literally saying, did you receive the notice of privacy policies? Do you have any questions about that? And I document in the notes, client indicate, patient indicates they received the NPP and had no questions, or, client received NPP and therapist answered questions about the NPP. Boom, done. I have my acknowledgement. Okay. So it doesn't have to be a signature per se. It just needs to be an acknowledgement that's documented in some way. And if I can't get an acknowledgement for some reason, then I need to document why I couldn't. Like maybe the person, in a medical situation, could be the person was passed out and unconscious. And by the time they came to, they were in a whole nother ward and I didn't get to them, right? So I'm going to document that, they'll need to get that when the person is awake. Okay, so there are some guidelines which the video went over, but basically, making sure that you get, that you respond to any request for HIPAA information within 30 days, that you just got to be responsive to your client, right? Now, I will say this, that if I know disclosing client notes to a client could be harmful to the client at the moment that they're asking for it, I can delay. Okay. Now we have the new law that just came out, which honestly, I haven't had time to really delve into. So I'm going to try to do a kind of I want to look at that again and give you some more information in the second part, where we have to disclose. We have to give information in a certain period of time. So I will give you the second law I'll cover when we get back together. But for now, just know if a client asks for information, if they ask how I've disclosed their information, I have to tell them. So what I used to keep when we had hard copy files is I kept a written record of every time something was disclosed, what the data was disclosed, to whom it was disclosed, what was disclosed. The great thing about the EHRs is when I do that, it actually usually records it now. right? But if it's not recording the transaction, I might have to write a note in there, like, sent copy of medical records per patient's request to Dr. So-and-so and date it, right? But I document when I do something so that the client can see that, and that if they want it, they can have access to it. The one thing that's a little new, it's a few years old now, but if your agency is going to be engaging in research, marketing, or fundraising, you have to give clients the option in the notice of privacy policies to opt out of those actions. Okay, so fundraising, marketing, or research, they can sign to opt out of it and not get any solicitations about it from the very beginning. And they can change their minds about that at any point in time. Okay. Security rule is based off the NIST, which is the National Institute of Standards of Technology. And the NIST has certain guidelines for how we do things electronically. Right now, I would say, and we'll talk about encryption a little bit later, but 256-bit encryption is pretty good. So if you have everything, you try to get, like if you have a modem or anything like that, you want to have 256-bit encryption is going to be what the standard should be. It used to be 128, which is still good, but I would say that's more of a minimal. I would say 256 is the best practice. Okay, and it'll say it on the box. Like if you buy a modem, it's going to say what the encryption bit is. 128-bit, 192-bit, which you don't see that much, 256-bit. It's going to tell you, and that's how many combinations, that's the algorithm, like it would be nearly impossible to break that, but people do, they hack. Let's see, we went over some of these already in the video. I just want to see if there was anything. Mobile devices. My mobile device is locked, right, at all times. So if you're using, like I have two phones actually. I have an iPhone and I have a Google phone, my Samsung. This is my personal phone and this is my work phone, and they forever stay apart. Okay, so Facebook is on my personal phone. LinkedIn is on my work phone. So I have I distinguish what's on one phone versus the other. My Canvas, for example, is on this phone. My EHR is on this phone, not on my other phone. I never log into my EHR on this phone, ever. I keep them separated. All right, because I don't want there to be confusion. I use my iPhone for my work stuff because it is pretty darn secure, right? And Apple, I mean, the Samsungs now are much better encrypted, but I love my Apple when it comes to security. So this is the phone that I tend to prefer to use because it is so secure. And I have face recognition, I have fingerprint, I have a passcode. So there's multiple ways I can get into the phone, but not anybody else could get into it. Okay. So that's protecting your mobile. The other thing is I have the Find My iPhone activated so that if I lose my iPhone, I can wipe my iPhone. So I can wipe it remotely so that somebody couldn't get the information. Jerry?
This might be a nitty-gritty question, but so just to know how far into separating out, do you even have it to the point of these two iPhones are even on separate Apple IDs, or are they on the same?
Well, this one's an Apple and that one's a Google.
Okay, got it.
Yeah, but if I did, yes, I would have two separate Apple IDs. I would absolutely have two separate Apple IDs.
Got it. Okay, thank you.
Liz?
I was just going to ask, that seems kind of inconvenient. Is there any other way to do that?
No, I actually like it because of boundaries too, right? When I'm off, I can turn this sucker off, walk away, and still have my phone. And I'm not having clients, and no offense, guys, students, interfering with my personal life, right? It's, you guys call this one. This is mine over here, right? And I keep them separate. And it gives me that sense of boundaries, because with when you're in the virtual world, it does get a little fuzzy with boundaries, right? And so this gives me my office. This is like my office that I can walk away from. And so in that sense, I actually find it better to have two separate phones for that reason. Okay.
I guess is that required? I guess.
That is a best practice. It is not a minimal necessary. Okay. But if you did have everything on one, you would always make sure it was always password protected. Like if your EHR was on there, it would need to be double locked. So your phone would have to be locked with the password, and that would have to be locked. So you would never leave it logged in. That would be a bad practice. Does that make sense?
It does. Yeah. Okay. Thanks.
And then if I had my personal and my professional on the same phone, I would not let clients text me.
Okay.
Yeah. So for that
Good to
reason.
know. Thanks.
Icy?
Hey, Dr. Ellie, going back to records, do clients have a right to their records?
Yes, clients do have a right to their records, but I do have the right to delay giving them their records if I think it would cause harm.
Okay, I think I heard
Okay,
that.
now that's not an extreme today. Well, I can't delay it 60 days, right? We're talking about 24 hours or, I can say, let's meet and let's talk through your records, things like that. But I also am very cognizant of what I put in records because I don't want to make my client upset if they get and they're going to take things out of context, right? Now, there's a difference too under HIPAA between my progress notes, which is what I would put in my EHR, and my psychotherapy notes. And the court has protected this. So as a psychotherapist, as a therapist, I can write my own ruminations, my reflections on the case, like my case conceptualizations, like I can put my ideas about a case, I can make notes about resources I want to use, kind of my own ruminations about it, still need to protect those records, but they don't have to be disclosed. Okay, so there's a difference. Jerry?
And that's the psychotherapy note?
Yeah, psychotherapy note. So there's a progress note, which is where you're detailing out like, this is what the client did, we met by video on this day, the client presented as engaged and coherent, my SOAP note type of thing, right? My psychotherapy note is my own ruminations about the case and kind of thinking through like a journal of what I'm doing with my clients. Okay.
We have a question in the chat.
Yeah, I see it. So giving records, issues, giving someone their records.
So Dr. LA, I can just tell you even.
Yeah, go ahead. Thanks.
So my husband was in a mental health facility in Utah in late 2020. And as he thought he was there for PTSD, and he was there for 5 weeks. As he was leaving, I just emailed the facility yesterday. It's so crazy you're talking about this. As he was leaving the facility, they handed him his file. And when he opened it, so he's literally walking out the door, 5 weeks of rehab to come, to go back out into life. They handed him his file. And when he opened it, it said borderline personality disorder. So he believed that he was being treated for PTSD. He left, and he opened it reading borderline personality disorder, which we had also been starting to study because we didn't know what he was having all of these things. He ended up dying by suicide 6 months later. And it's taken me this long. It's taken me now 9 months to write the facility and to let them know 2 places where they dropped the ball. That was one of them that I thought was unethical. And also that his therapist didn't show up for their last appointment on the day before his discharge.
Yeah, so there's some unethical there. Like probably nothing legally wrong with that, but there was a lot of best practices that were not done. And there were some ethical issues there, right? Because you should always disclose the diagnosis to your client. You should talk that through with your client. You should answer questions about that with your client. I also see diagnosing as a collaborative experience. So I want the client to be part of that process, right? I want to educate them about that process. And then not showing up, that's just negligent. I can't make that as a case definition, but you need to be there for the client so that you have closure. Termination is an ethical responsibility. Now if something came up and that clinician had COVID or their kid was sick, then somebody else should have stepped in and been part of that process. That would have been acceptable because we can't always control things outside of it, right? Okay, one more question and then we're going to move on. The progress note is discoverable, Tammy. The psychotherapy note can be protected in most cases in court. Jerry?
It's okay. I know you need to move on. I can ask.
All right. Well, y'all can ask lots of other questions too. So let's see. And you can see where I've tried to determine where this is mandatory, right? Where this is required and where it's a best practice for you in the notes. So let's scroll on down. I want to talk a little bit about breaches. So breaches happen. It's hard to not have a breach. Breaches happen. So again, if it's more than 500 records, not only do you have to tell your clients and HHS, you also have to notify the media. And there's actually a script that you have to give the media saying how many people were affected, what you might have seen some of these in newspapers, online, you might have gotten an email about a breach notification, and it's going to tell you like what was the type of breach and what happened. And they won't give you like the nitty gritty, but they'll give you an idea, like we're pretty sure that your social security number was seen, your date of birth was seen, but it wasn't taken, it was just seen. You'll see that language, and that's what they're talking about. If it's greater than 500, you also have to notify immediately. Like as soon as you find out, you got to call HSS. They have an actual, you can report it on the website. You have to get in touch with OCR. You have to notify the media. Like that needs to be happening very quickly. If it's less than 500, you should report it immediately, but you can just save them all up and do it in 1 year. You can do it annually and you wouldn't get in trouble, but they'd rather you get it to them sooner than later. Now, this is what you have to put in a breach notification. And here's what the violations are. They're darn expensive, right? And there's 4 tiers of breach. The first tier is unknowing. Like there was no way for me to know that. There was no way for me to anticipate that. A great example of that is in the county where I used to live, terrible situation, but I think it's a great example of unknowing. So what happened was a social worker got assaulted by a non-custodial parent who was trying to find his wife and kids. And so he attacked her, terrible things, beat her. She lived, but barely. And when they did the investigation, they found out the way he had found the social worker and he found his wife was because he had gone to child support services and he had asked the person who was wearing glasses at child support services if his checks had cleared for paying for child support. Somehow he knew that his wife's address would show at the top of the screen, and he read her address from the person's glasses. There's no way that child support services could have anticipated that, right? Like was there a way to remediate it? Yes, they put no glare screens up so that it didn't have that reflection coming, but that was not something anybody could have like really thought of, right? So that would have been a good example of tier 1. Tier 2 is, I should have known about this, but you know, I didn't know, and I fixed it as soon as I could, but it was like, you know, there was reasonable to understand that I should have thought of that, but it was clear that I was trying to take efforts to make things secure, and I just oversaw that. It wasn't malicious, wasn't intentional, right? An example of that is when I set up, I got a lease with a copier company, and of course we had fax then, and they plugged the fax line into the copier. And, you know, people could come and they could make copies, they could print things. It was really cool. It was like one of those big machines that did everything, right? Well, we didn't put any type of physical safety on the fax line going into the copier. So because the fax line was plugged directly into the copier, anything that was copied, printed, or faxed could be pulled from the copier through that fax line. So we had to put this buffer on it, which is actually kind of like a surge protector that would only allow information to go in and only go out when a code was entered. So we had to enter a code before information, like you enter a security code and then you could do a fax, right? And so that allowed it. We also had to implement, everybody had to enter a code to get their printing job, and they had to get a code to be able to copy. Right? Because then also if something was left on the copier or left on the printer part, I could see who the last person was to use the copier or printer so that I could remediate, right? Because that's not secure. You can't leave things on the printer copier, right? Now, interestingly, I had a lease on that copier, and with the business associate agreement, what we determined was because that hard drive in the copier keeps a copy of everything, that I couldn't send that leased copier back to the company. They actually just gave me the machine at the end of the lease because I had to destroy the hard drive, which is interesting. Try to get rid of a huge copier. It's not easy. So, okay, the last two are willful neglect. Willful neglect corrected and willful neglect not corrected. I have two great examples. So one of them, one of my colleagues, has a really cool newsletter that he sends out to his students, to his supervisees, his clients, his former clients, community partners. And he sent out the newsletter one time and didn't blind copy it. So everybody could see who everybody else was on the list. As soon as he hit send, he realized his error. He sent out a retraction, said, please don't, view that, please delete that. I'm going to resend it out. He also made an account with MailChimp so that he could then do it through there so that it was protected and it would never happen again. He then reported himself to ACA, NBCC, and the licensure board of what he did, because we didn't have the notification rule at that time, and said, I did this, I messed up, here's what I've done to fix it, right? And the board actually said, wow, you've done a great job. Thanks for, this is, again, not what you do, it's what you did with what you do, right? And the board said, we will not even find you as at fault for this if you will do 2 presentations over the next 2 years to the state association explaining what you did and why, so that others can learn from your mistake. Boom, done. Okay, that's an example of a tier 3. So willful neglect, I made a mistake, but I corrected it as quickly as I could. Tier 4 example is a psychologist in Raleigh who did the same thing, basically sent out an email. It wasn't blind copied, but then she tried to delete it from her server. She tried to say somebody else sent it. I mean, she did everything in her power to say it wasn't her, right? She ended up getting fined $250,000, had to take out a full page ad in the Raleigh News and Observer apologizing to the community for her breach. And she got, she didn't get suspended, but she was like, she had to go under supervision for a certain period of time and couldn't practice independently. So it was pretty serious consequences for her because it was willful neglect and she refused to correct it, right? She was being kind of, not having integrity about it. Okay. Does that help you guys see the difference between the 4 tiers? And I think last year, it was actually a little lower than normal. I think last year, the HIPAA, if I remember from the breach report, and I have it cited here, this is the breach report. I think last year it was like $5.5 million with fines, but I think the year before it was like 18.6 million. So they were a little less active on audits and stuff during the COVID, but it's a lot of money. It can add up really quick if you get a breach, because you have to pay the fine for every incident of the breach. Right. So if the minimal, yeah, exactly, Melissa. If there's $1,000 minimum and it breaches 50 people, that's $50,000. Okay. Yeah. So we do have a responsibility to audit, and HHS may select us to audit as sole practitioners, as small agencies, as middle-sized agencies. You can get a letter from HHS. There's 3 letters you don't want as a clinician. One from the IRS, one from HHS, and one from your board. Okay, unless you're asking for it. So those are letters you don't want. But with HHS, they will send you a letter and they will say, we are going to conduct this type of audit on you. And you have to respond to that. You have to write a written response, and they'll give you a time period, usually 90 days. And they'll say, we want you to audit between this date and this date. Tell us if you had any breaches, what protocols are you using? What's your process? How do you train your staff? They're going to give you basically a list of questions. And on this website here, there's actually a spreadsheet. It's not really well done though. Like the spreadsheet's like that big and it has like 10 columns. And I haven't quite figured out how to pull it out, like how to download it or anything so you can use it more. I was actually going to do a call to HHS and ask them, because it's not very user friendly because you have to like scroll through these tiny little columns. But what it does is it says, here's this type of audit. Here's what we're looking for. Here's some resources. And here's the questions you would have to answer to respond to that audit. Okay, so they give you the guidelines. It's fully transparent. They're very transparent about the process. Okay, so that's how it is. I think the two big things that I see when I'm consulting that I see are missing from a lot of programs is remediation plans. Like if an employee does something, how are you going to remediate that? What's going to be the consequences of that, right? At what point does somebody get fired because of it? At what point do they have to take a class? When do they have to, what is your response? So you kind of have to think through, if somebody leaves something on the copier overnight, what's the consequence of that? Right? If somebody leaves a file out on their desk or leaves their laptop open without it, being password protected, what's the consequence of that? What are you going to do to help that employee learn from that? Right? And if it keeps happening, at what point do you have to fire them? Right? And what are you going to do if it's just you? I'm a sole practitioner. I have my own private practice. I'm the only one. Nobody's looking over my shoulder. How do I hold myself accountable? Right? You have to write that stuff out. And there's lots of tools. I'm going to show you a toolbox where you can go and they have examples. Like you don't have to create this stuff from scratch. There's lots of examples on the web and stuff that you can use. Just be sure it's current because the rules have changed. So you don't want to pull something from 1998 because that's going to be way out of date, right? You need something that's been more recent. So policies, processes, tracking or documentation equals compliance. So you got to have all three parts. Okay. And APA used to sell a HIPAA compliance package that you could actually just buy and then modify. So kind of cool stuff. One of the other components of HIPAA is business associate agreements. Okay. So these are people that have access to personal health information of your clients. So brainstorm with me either in the chat or out loud, who is somebody that you might need to have a business associate agreement with that would have access to your client's information?
Zoom.
Zoom, yes. Internet provider, Chris says. Insurance company, Hammy says.
Email accounts.
What did you say, Jerry?
Email accounts.
Email accounts, possibly, yeah. Cleaning services, Diana, good one. Billing services, yep. Okay, so let's break down some of these. And if anybody comes up with others, we can put them in there. Phone companies, I do not need to have a BAA with. They fall under FCC regulations, which are actually stricter than HIPAA. Okay. I do not need to have a BAA with my banking institution, like my credit card processors or anything like that, because they fall under NIST and FEC regulations that are much, much stricter than HIPAA. Okay, so that's already taken care of. Definitely Sasha, tax services, CPA services, administrative services, Tammy. Cleaning services is one of those gray areas. So I actually had, when I had a large private practice that was physically present, I did have a BAA with my cleaning service because I did not trust everybody else was going to do their jobs. And they might come across a file. They might come across something that was thrown away that shouldn't have been. They might find something in the copier, right? And so what I did actually was kind of fun is I worked with this cleaning company and they agreed to send the same team in to clean my office every time. And I trained that team on HIPAA. And I trained them what to do if they found that. And this actually ended up being a really mutually beneficial tool because then they got additional contracts with other medical because they had the HIPAA training that they had gotten. And every time they got another account, they deducted $10 from my fee. And so it was awesome, so it added up. So it ended up being mutually beneficial. But then if they found something, we had given them a key to a lockbox. And if they found a file, they found a piece of paper, they found something with a client's information on it, they would put it in that lockbox with a note where they found it. And then I would check the lockbox and then I could do remediation if needed. Right. So that was really helpful to work together. My CPA, I do not have a BAA with, but I do have a BAA with my bookkeeper. Okay, my bookkeeper can see which clients have paid because she has access to my checking account. She has access to all of that. So she can see who's paid. My CPA only gets the final report, profit loss, things like that. So there's no identifiable client information for my CPA to see. So that's the difference between those two. The one that I haven't seen, and maybe I'll put it in here, maybe Ashlyn might have mentioned it, but is the copier fax company. Yes, because they have that copier is keeping a copy of everything you've ever made a copy of. Okay, you can pull those back off. It's kind of creepy. And then the other thing is your tech person. So if you take your computer somewhere to get IT, like my Mac, I always go to this one company, one guy who always works on my Mac, right? I have to have a BAA with him because my client information is on my computer. It's secure, it's password protected, but okay, this guy's pretty smart. He could probably get in there, right? So I have to be careful about that. So I have a BAA. I do like that one, CJ, about a landlord. You don't have to have a BA with your landlord, but what I did is with my landlord, I put in the contract that, you know, the landlord would be respectful of the type of business that we did and wouldn't, you know, be sneaking around looking at stuff, basically. Better language than that. But right, so we had an agreement. I mean, he respected the fact it was a medical office, right? So that was really helpful. I was trying to see if there's any others that came up. If I was contracting with someone to do like personal assistant or something, or do my scheduling, I would absolutely need to have a BAA with them. Family, yes. Okay, so Melissa, that's a great question. What about family members of sharing computer and iPad? Okay, first of all, bad practice. And I know it's hard, but you really need to have separate computers. That is one where I have to say, yes, you have to have a separate computer, okay? And you need to have one computer that is strictly for your business, for your practice. So like my Mac, it has got so much encryption on it and security, it's insane, right? And I have my antivirus and my anti-malware and all of that on my Mac, even though technically with the Mac, you're not supposed to need it. I add that on there just to be sure. Because one of the things that has, that I have done to somebody else, my older child, is you can send somebody an email and then have remote access to their computer. Okay, so if somebody like an ex-husband of one of my clients wants to find out when the client is coming for session, if we're meeting in person, or when she's going to have session because they want to record it or whatnot, they could send me an email. I don't even have to do anything other than just click on that email and see what they said. And they could download something to my computer that would give them access, remote access, to be able to see anything I pull up on my screen. Could potentially give them access to my files. Okay, so I could even just respond back, I'm sorry, I cannot confirm or deny that this person is a client, right? And they still already have access. If I don't have antivirus, malware, all of those things already on my computer. Okay, I did this to my older child just to see, because they were being homeschooled for a little while and I felt like they weren't doing the work they were supposed to be doing, but they kept being really sneaky about it. So I sent them an email and I got full access to their computer. So when they pulled up Netflix, I got to see it. So I had a little miniature screen here that showed me exactly what Ren was doing on their computer at all times.
Keep that. Okay.
Yeah.
Keep that not for my clients, but for my child.
Yes, exactly. For your older one, right? Yeah. So, but I did disclose afterwards that I did it, but it was a little experiment that Mama did. So you can do that. So you need to have malware, you need to have antivirus, you need to have all of those things on there so that you can protect, and you need to have a separate computer for your work stuff. Don't let family members use it. Your kids shouldn't be watching shows on it, because the last thing you want to have happen is somebody to send you a message or something and it shows up, you know, and your kid sees, you know, I mean, I don't hope your clients would do this, but, you know, I'm thinking about killing myself. Can you call me? Do you want your kid to see that? I don't, you know, so you have to keep those worlds separate in that case. That one's a big one. Okay, keep going. So business associate agreements. The good news is you don't have to write the contract. Okay, the contract's already written on HHS's website. So they literally have a contract already written. You can modify, you can tweak it, but it's already there. You need to update those annually. Okay, so every year you need to get a new one from those people. If you're not sure somebody is a business associate, you can use one of these decision trees to help you decide if the person should have a business. I always err on the side of getting it versus not having it. I think that's the best practice. And I redo mine every May. And the reason I do that is my liability insurance is due in May. So I just take care of all of it at one time. Liability, I renew all my professional organizations, I do my licenses. May is a very busy month, right? But those are things that I just put on my calendar and I know that I need to do. Okay. All right. So risk analysis. What are my risks for possibly disclosing PHI in a way that's not appropriate? Create policies. right? What's my NPP say? What does my business associate agreement say? How am I going to remediate, when situations happen? What am I going to do if there's a breach? I'm going to answer all those questions. I'm going to train my staff or whoever's working with me about that. I'm going to document that training. I'm also going to document any use or disclosure of PHI, protected health information, right? Either in my electronic health record or in written form. Probably better to do electronic. What security measures do I have? Do I have the best encryption? Am I using the right type of modem? Am I using a secure wireless system? So if I'm using Wi-Fi, I need to make sure it's secure, right? It needs to be encrypted and secure. And I would say that it needs to be probably at least 1200 megapixels per second, especially if you're doing video. Okay, you'll see whenever you do things, it'll say like 1200 Mbps or megabytes per second, Mbps. So 1200 or higher is the best. Same thing with my power line adapter. My power line adapter is encrypted and it has 1200 megabytes per second. Okay, so it gets the best quality. So with security, I need to create that secure environment. I also use business internet. I don't have a personal internet account with Cox. I have a business level internet. Yes, it costs more, but I have a higher level of security. When you use personal internet, you're actually sharing the internet with everybody on your street. And if you're at the end of the street, you have less internet than everybody else. You get less download, upload speed, trust me. With business, I have a direct line. When they tell me I'm getting 100 gigabytes, I'm getting 100 gigabytes. And if I don't, I can complain. And I have a tech person who is assigned specifically to me and has to respond to me within an hour. Right? Whereas if I have personal internet, we'll be there sometime this week. Right? So that gives me more responses. So yes, I pay a little bit more, but it's worth it because I have more security, better upload, download speeds, and I have pretty quick service. Okay. All right. And then evaluating, right? I have to constantly evaluate. Am I doing this right? Has technology changed? Do I need to change my encryption? I have to stay current. That's where those professional associations, blogs, newsletters, webinars come in handy so you can stay current with whatever you're supposed to be doing. I've created this high-tech HIPAA toolbox for you, high-tech being the enforcement portion of HIPAA. And even if you're saying Canada, these tools can be helpful because the Canadian law and the American law are very similar. So these resources can be really helpful. And some of the things I wanted to highlight are, this is specific to some of the concerns we have as mental health professionals. What if a client has an opioid overdose? What if a client gets committed? What can we tell their family members? Things like that. This will help you with that. And then here is that link I was telling you about for those of you that are in schools that talks about how FERPA and HIPAA work together. I was at Meredith College in Raleigh when FERPA and HIPAA came out together, and we were so confused in the counseling center. We had no idea what needed to be HIPAA, what needed to be FERPA, and there was really no guidance. And this page actually helps with that. Okay. All right. So let's jump into a few more things before we finish up. Let's talk about state lines. And this is the part that everybody really doesn't like my answer. And that is, you need to be licensed in the state or province that you're in. If there's licensure available, you need to be licensed in that state or province that you are functioning in or have a credential within that. The boards that oversee, provincial jurisdictions or state jurisdictions, they only have the capacity to give you the ability to work within the boundaries of that jurisdiction. Okay, so I live in Virginia, and Virginia can only give me the authority to work within Virginia. They can't tell me that I can work in Tennessee, West Virginia, Maryland, DC, North Carolina. Okay, now I personally have a license in Virginia and North Carolina, so I can work in both states. But here's what happened. When I moved from Raleigh to Williamsburg, I had to wait a year before I could see my clients again in North Carolina, because North Carolina has a rule that says the clinician must be licensed where the clinician is located and where the client resides. And I wasn't licensed in Virginia. So I couldn't see my North Carolina clients unless I was in North Carolina. So I literally would go back and forth every couple of weeks, and I would go across the state line, stay with a friend, see my clients, come back across to Virginia. Okay,
Oh.
what was the chances of me getting caught? Probably not very much, but the risk comes in if I had had a client in North Carolina who say had unfortunately committed suicide, right? And their family sued me for negligence. My liability insurance could have said I was practicing outside the scope of my practice if I had been in Virginia and denied me coverage. That's where the risk comes in. Talia?
So you were, let me just make sure I'm clear. So when you moved from Raleigh to Virginia, you weren't licensed in Virginia yet. And because of that, that's the reason why you were making the commute. Because how long does it take you to get licensed in another state?
Normally, it should have only taken about 3 months, but because of the pandemic, I could not get anybody to give me my freaking file from North Carolina.
Okay.
Like, because there's now this thing called endorsement with a lot of states. If you've been in good terms, like if you've been, I can't remember the actual words, but I've been licensed in North Carolina since 2003. Okay. And I've good terms. I've never had a complaint. I've been a good person. I've like done everything I needed to do. Right. So I have a great, strong license. I have a supervisory license even in North Carolina. So ideally, I should have been able to come to Virginia, or even before I came to Virginia, I should have been able to apply for what's called endorsement. And it should have been like 3 months. But because nobody would go to the darn warehouse and actually get my file for me during the pandemic, I had to wait a year. So it took a year for me to get a copy of my file. As soon as I got a copy of my file, they processed my license and I was licensed in Virginia. So now I see clients in Virginia and North Carolina. Because I'm licensed in both, right? In good standing. Thank you, Susan. Sometimes the words just won't come, right? So in good standing. So I had license in good standing. It was unrestricted. So like in North Carolina, I have a licensed clinical mental health counselor associate. That's a restricted license. You can practice, you can have a private practice, but you have to have a supervisor. You have to do supervision every 40 hours. I had a license in good standing, unrestricted for at least 5 years. I didn't have to take the test in Virginia. I didn't have to take any extra classes. They just took my licenses. Okay, you're good.
I love that. That's kind of their new thing, I guess, in response to
it's being built up. Yeah, we're hoping we'll get a compass, which is where you have a contract where like doctors and nurses have this, where if they go to another state and they're licensed, a lot of times it just, they get a license in the next state, right? They're good, or they can practice as if they had a license. We don't have that yet. We're trying to get the compact now. Maryland, Virginia, a few others have signed on it. So we're trying to get states to add on to that so we can have a compact like the other professions. The map is just a picture, Hey, Joe.
So I'm thinking about sort of the case of, so how do you handle the military associated client stationed in Norfolk and they get all of a sudden PCS down to Corpus Christi?
Yes, it's a nightmare. It's a nightmare. Yeah. So with military, you have a little bit more leeway, right? If you can say that, because it would be do more harm not to continue working with them. So that's your ethical decision making, right? So in that case, I can make a claim that I would do more harm to not support them. But my partner just went through that, moved from, a few years from Savannah and had to go on a wait list to get a counselor here. Right. So there is some problems with that. If you're working at the VA, if you're actually employed by the federal government, you can have a license in one state and serve all states as a VA employee. But if you are an independent private practitioner, you do need to be licensed in each state, and every state has a different rule. There are 4 rules and every state has different ones. So like North Carolina's, you have to be licensed where the therapist is located and the client resides. In Kansas, you have to be licensed where the therapist is located and where the client is located. In Virginia, you have to be licensed where the client resides. In Tennessee, you have to be licensed where the client is located. So there's 4 different types of rules, and every state you have to find out what rule does this state have. Then let's fold in residency rules. If I go to Florida and I go to Disney for 2 weeks, for 14 days, and I live in the same place those 14 days and I don't move, I am now technically a Floridian. 14 days. So it gets really complicated, right? So the best practice is to be licensed where your client is located and to be licensed where you're located. That's the best practice. Okay. Now, is it possible to function ethically across more than a few states? I would suggest not. Okay. I have to know when I get a client, like the other day, I got a client in Hildebrand, North Carolina. I didn't even know where Hildebrand, North Carolina was. All right. So I get this client from Hildebrand, North Carolina, and I have to go pull up the map and go, where the heck is Hildebrand, North Carolina? Right. And then I find out, oh, it's near Hickory. Oh, I know Hickory. I got connections in Hickory. Right. I have a colleague in Hickory that I know if I have a client emergency, I can reach out to that colleague and say, hey, Laura, I need a food pantry, what food pantry? And Laura would be willing to call me if she had a client, say in Wilmington. She knows I know Wilmington. She'd call me and say, hey, I got a client in Wilmington. What resources are available, right? So we kind of network and work together. But as a therapist, I'm responsible for knowing what the emergency services are and how to get those emergency services to my client. So I can't do that well across many, many states. Right? To me, 2 is really my limit, right? I have one friend that's licensed in 5 different states. And I'm like, more power to you, Kathy. And she works with military, like Pedro was talking, she specializes in working with military families. But she knows everything about the bases. I mean, she's wonderful about the areas where there are bases and knowing those communities and everything. And she's really worked hard to know all of those. And she's a military wife herself. So, it's like figure out where you can focus and where can you know about the resources so you can support the client effectively. So it's not just about licensure, it's licensure plus liability plus knowledge to be able to function ethically. The VA is the only one, Sarah, that I know of right off. Now, FEMA has a temporary order, so they can do an emergency order for 30 to up to 90 days, or if there's a federal mandate of an emergency that will allow people to function. Like if after Katrina, I could go down to Katrina and I could work in Katrina if it's under a federal emergency. Okay, so FEMA is the only other one, but that's only temporary. Now, I'm going to show you guys these resources in just a second, but there's some wonderful resources that will help you know about laws and things like that. So yeah, thanks, Susan. Susan posted the compact, so that's really great. Chris, the licensure requirements for, yeah, let's talk about that. So there's a lot of companies out there who try to get you to come and work for them, right? My suggestion to you is really be careful and read the fine print, okay? A not to be named company did this with a colleague of mine. I had somebody in one of my meetings and she said, oh, my company said they would take care of everything. And I said, okay, companies are not licensed. Individuals are licensed. You are responsible for your license. No company will take responsibility for your license. And she's like, oh, what do you mean? So do you have a copy of your contract? And she was like, yeah. I said, let me read it over lunch. So I read it, and sure enough, in the fine print, it said that X company will not be responsible for the therapist abiding by legal jurisdiction, that the therapist is responsible for abiding by legal jurisdictions. And so basically, they were hanging her out to dry. They were giving her clients from all over the place. Which, first of all, I don't think you can be knowledgeable enough to have people from all over the place because you can't be ethical and knowing your emergency services. Second, they were not restricting her clients to the communities in which she was licensed. All right. So I work for a company called Able To. I'm actually a rehabilitation counselor by training. That's where my original training is, in rehab counseling. And so I work with individuals who have chronic and terminal illnesses. And in my private practice with Able To, they only assign me clients who are in the zip codes of which I am licensed. All right. So I had a great example the other day. I had a client that got transferred to me, and the client's address said Virginia. But when I talked to the client, they had moved to Tennessee. And I had to tell them, I'm so sorry, I'm going to have to find a counselor who's in Tennessee. I'm not allowed to see you because I'm not licensed in the state of Tennessee. Right. So you need to be careful with those companies because some of them make you believe they got it covered. But trust me, when something goes wrong, you're going to be on your own and out to dry. Okay. So important to know those risks. Okay. Apps we're going to talk about a little bit later. Okay, good. All right, so I also provided, Virginia has some good guidelines that they're working on them, because I just did a report for the Virginia board and trying to make some of the things regulations and some laws, but for now they still have these guidance documents. So I just gave you some examples of what a guidance document is. So states will have guidance documents, which actually are not enforceable in court, believe it or not, but you still get in trouble if you don't do them. Okay, they'll try to remediate you and things like that. But if you sued them, they probably wouldn't stand up in court. Then you have regulations. These are the administrative code. These are the ways they implement the laws. Okay, so these are, how do you apply to become a counselor, right? As an example of that. And then you have a law, which tells us what a board has the authority to do. Okay, so what part of the executive branch has the authority to do what? So laws give authority. Regulations tell us how to implement the law, and then guidelines are resources available to help us do best practices, but typically will not stand up in court. Okay, but you have to follow all of them if you want to have a smooth, easy ride. And usually they're there for a reason, right? They're there to protect and so that we don't do harm. Okay, so there's some guidelines there from Virginia as an example. I want to show you guys CCPH, which is one of my favorite resources. There we go. So this is the Center for Connected Health Policies. The Center for Connected Health Policies is your go-to for legislation, both federal and state. Okay, so I can go here and I can choose Virginia. And here's Virginia. It'll tell me different policies. It'll give me the COVID restriction, Medicaid, and private payer and professional requirements. So it'll tell me, okay, what are some requirements that we have regarding telehealth, right? And I can look at consent requirements, because some states like Tennessee have really weird minor guidelines. Like in order to see a minor in Tennessee via telehealth, at least this was the case before COVID, I don't know if it's still true, you had to have a guardian present in the room with the teen while you were talking to them. How effective is that counseling going to be? Okay, so, you know, so you have to really understand what those requirements are. Okay, and this is for all helping professions, but it will give you like this one's specific to dentistry and things like that. But you can look up different states. It also tell you what legislation or regulations are pending. Does it cover everything? No, it's impossible. So you have to have multiple sources. So the other source is actually on my phone, and that is the Epstein-Becker-Green Telemental Health Laws. Whoops, I don't know if it'll come up like this. Can you get it to show? Anyway, if you type in on your Google Play or on your Apple Store, Epstein-Becker-Green Mental Health Telemental Health Laws, it will come up. And what it does is I can search by state guides. So like, I'm just going to, so it has a bunch, I don't know if you guys can see that, like states, it has all the states listed, and it's not showing up really well. And then you go down here, I'm going to go to Virginia. I'm going to click on the picture of Virginia, and it has key terms. It has guidelines for psychiatrists, psychologists, social workers, counselors, marriage family therapists, advanced registered practitioners, privacy, confidency, minors, follow-up care, coverage, reimbursement, and controlled substance. It covers a lot. So when I click on minors, it says that there are no specific guidelines for minors in Virginia, which is really cool, right? Right in my hand. I can look this stuff up right away. And they do a great job of keeping it. Epstein-Becker-Green is a lobbying firm, but they have a whole division that focuses on telehealth, and they really do focus on educating both the public and politicians about what's going on. They've done a lot of great work in trying to get telehealth moved along legislatively in the country. But I love this app. It used to come out as a PDF, like every 6 to 8 months they would do it, and it's static, right? And it doesn't get updated. This, they keep current, and it's a wonderful resource. The other resource is the Telemental Health Institute. They have some great resources. You can check out all sorts of things. Raymond runs it. He's really cool and does a lot of great stuff. And this is in Blacksburg, Virginia. I was trying to remember where the state one is, but they have a state resource guide right here, state rules and regulations. And then I click that. And they have this, and I can click on the state that I want. So like here, go to Virginia, boop. And then I can click on any of these to learn more about the laws in Virginia. Okay, so great resources. No one of these will have all the information. I look at all three if I'm trying to understand a state, okay, because somebody might have missed something. So sometimes you need to have multiple sources. So those are three really great resources for understanding. So you have the CCHP, which is a federal agency, Epstein-Becker Green, which is a private agency, private lobbying agency, and then the Telehealth Certification Institute, which is a private organization as well that does a lot of wonderful trainings. Okay. And then as supervisors, if you're doing supervision, you really need to check out the laws too. What does it mean to do supervision? Like in North Carolina, face-to-face supervision, what does that mean? Can it be virtual? How much of it can be virtual? The other thing is to really be aware of your liability insurance, right? So when I renew my liability insurance in May, I will send an email to my liability insurance and I will say, am I covered as an in-person counselor? Am I covered as an online counselor? Am I covered as an in-person supervisor? Am I covered as an online supervisor? Am I covered as an on-ground teacher? Am I covered as an online teacher? I ask these 6 questions every year, right? And then because I also do some consulting, I will ask about consulting as well, right? Is this covered in my liability insurance? For a lot of liability insurance, they only cover in-person counseling. Now that may be changing with COVID, but you often have to buy what's called a rider to be covered for online services, which is an additional fee that you pay to get that coverage with your liability insurance. So make sure you check out your liability insurance, not once, but every single time you renew. Okay. And here's a very novel idea. Read your policy.
Who do you go through?
Say that, Atilia.
Who do you use?
I use CPH associates, and I've had them since I was a graduate student. But you guys have HPSO, which really we didn't have then, you know, through ACA. So if you start with them, I would stay with them. Okay, because there's 2 types of liability insurance. There's the type of insurance where you're covered at the date of incident. And then there's another type of insurance that covers you at the date of complaint. There could be a gap there if you're switching between liability insurance, right? So if you had date of complaint insurance at the time that the event happened, and then you switch to date of event insurance, there's a gap, right? Because you weren't technically covered the date of for the date of event. Your original insurance was date of complaint.
So like when we sign up with ACA is who I signed up with as a student.
Yeah, so that'll be HPS.
Preparation.
Mm-hmm.
Okay. And
Yeah.
so then transition from a student to a
new professional, you'll get a discount for 2 years as a new professional, and then you'll move into the full professional. Mm-hmm.
Okay.
Yeah. And if, you know, for a while there, I was doing both in-person and telehealth, and I had a walk-in basement in my house, and I converted that to my office for a little while to save some money. And so clients would walk around my house and they'd come in the back door, and I would meet with them in the basement of my house, which had a separate entrance, which was great. It was a wonderful way. It was awesome. I also had like rocking chairs right outside the door, and we would sit on the patio and look at the woods. It was a wonderful space for a counseling office. Okay. But if somebody had fallen on those stairs or fallen on the walkway, I would have been responsible, and my homeowners would not cover it if I was running a business. So the other piece is I had to buy a rider for liability insurance for falls, right? For people getting hurt on my property. So that's another piece. If you have people actually come to your property, you have to have additional insurance for that as well. Okay. Now, if you're doing virtual, that saves you lots of money, lots of overhead. Okay, in that way. But you just want to make sure your insurance is covering that as you go through there. I'm going to stop there and just open it up for some questions, and then we will be able to cover the rest in part 2. So what questions do you guys have? What thoughts do you have? The questions I just said. Yes, Char, I'll tell you what, I will add them to this, the questions I asked my liability insurance, and then when we start the part 2, you'll have an updated handout. So questions, I don't know why I've never put those in there. That's a good point. Questions for liability. Okay. what questions do we have? I couldn't have possibly answered.
Well,
Go ahead.
Sorry.
No, that's right. Okay, Talia, you go, and then Pedro can go.
But just the pickup from where you were mentioning how you have a workspace attached to your house. How did that work? And I mean, how safe is that?
Yeah, so I only saw couples that way, and I did a lot of screening beforehand, right?
Okay.
Because I also have a history of working with individuals with borderline personality disorders, and Melissa, I feel you. I had a history, so I really screened very heavily. And for many of these people, there were people I worked with for literally years. So yeah, not everybody got to come to my house. Okay, Pedro?
Just a quick follow-up on the issue of liability insurance as students. We need it when we start field work.
Right, when you start field work. But if you're an ACA member, you're technically already covered.
Yes.
But and I would encourage you to have ACA membership from the time you start as a student forever. One other thing about liability insurance is never take a break on your liability insurance. If you have to eat Cheerios for a month to pay for your liability, you eat Cheerios and you pay for your liability. Okay, so women especially who might think, oh, I'm going to have a child, so I'm going to take a break and I'm just not going to pay my insurance. You increase your level of risk and they rate you at a higher level of risk with every break you take. If you take 3 or more breaks, you may not be able to get insured. So it's important to know, don't take breaks with your liability insurance. You need to stay licensed. Once you get one, keep your license. If you get liability, you stay with your liability. Those 2 things you have to budget for. You need to pay for those at all cost. Jess and I had some slim years, trust me, where I was eating Cheerios so I could pay for my liability insurance. Okay. Yeah, actually, I think there are definitely other considerations with home. We could do a whole nother webinar home based. Okay, so I don't want to get too much into that, but this is one of the reasons why I do love virtual, right? Virtual gives me so many opportunities, not only to protect myself and my family and be here with my, my kids and my partner and things like that. I mean, I can see a client and then I can go downstairs and fix dinner and then I can come back and see another client. There's a lot of flexibility. I can see a client, teach a class, see a client. It's really kind of cool, right? This is so flexible. However, well, I would say, and I also get insight into my client's world. And we're going to talk some more about that in part 2, because I love doing couples or family work because I work with sexual marginalized populations. So usually there might be a triad, there might be a polyfamily or open family, and I get to see them in action at home. I distinctly remember this one case where it was a husband and a wife. The husband had just come back off deployment. They're talking. The house looks great. The couch, the table, it looks great. Everything looks wonderful, right? And she starts ragging him about something that he wasn't doing. He goes, oh, you want to be like that? And he picked up the laptop and he goes, look at the rest of the house, Dr. LA. The rest of the house is a disaster, right? And so it was kind of funny, like you really get to see who goes and checks on the kids, who responds to the crying baby, right? Like it's a really insightful addition to your counseling.
Dr. LA,
yes.
You spoke briefly about business agreements. What do you call agreements with other physicians that take care of the client? Is that out of consent from the client?
Yeah, so there's one of the things that HIPAA does allow us to do is consult with each other, right? But I still have to send an authorization. Now, if it's an emergency situation, or I know something's going on, like, oh, this was a fun one. Not my favorite, but so I had a client who I was seeing who I found out was harming herself sexually because she was attracted to her nurse practitioner. So like she literally put razor blades in her vagina so that she would have an excuse to see the nurse practitioner. So that clearly required some consultation. Like we needed to talk, right? We needed to talk. And so in that situation, I felt totally appropriate. I documented my decision, my thinking. I consulted with a couple of people. Everybody agreed we needed to work together. And so in that case, I reached out to the nurse practitioner. We actually created a very great working relationship, and we were able to set some boundaries and limits. Like she was only allowed to see the nurse practitioner for her annual appointment. For any other thing, she had to see this other doctor that she really didn't like that much, type of thing. But I mean, that one did escalate to harm, and the client actually got committed for trying to harm the nurse practitioner. But because I had also built that relationship with the nurse practitioner, when I called the nurse practitioner and said, you need to leave town now, she left. She got her kids, her husband, and they left town. You know, and then the hospital lost my client when I committed her, and she ended up sitting on the nurse practitioner's car waiting for her to get out of work. But of course, the nurse practitioner wasn't there because I had advised her to take her husband's car, not her car, so that the client would think that she was still at the office. But I mean, that's just crazy. You know, that stuff, just craziness. Not saying the person's crazy. I'm just saying that whole situation was just out of hand. But we got it handled, and the person got help, and you know, we were able to de-escalate that situation. But if I hadn't had that working relationship, it would have been really hard for somebody just out of the blue to say, you need to leave town, like leave town now. Right? It would have been as, I think, effective. Melissa?
How serious did it need to get for you to be able to violate confidentiality, not violate, for you to be able to break confidentiality to talk to the nurse practitioner? Like,
once I realized that my client was doing self-harm, that gave me what I needed to break. Remember, we can break confidentiality with self-harm. So I needed to work with the nurse practitioner, figure out how to get this client to stop harming herself so that she could see the nurse practitioner. Right? Yeah. Pedro?
I think it was earlier, you mentioned, I think it was in the context of the notice of privacy practices or confidentiality. You mentioned, you know, sort of the client's right to change their mind in terms of their information and disclosure and whatnot. I guess in the annual re-signing or re-acknowledging of the forms is when the client is supposed to sort of realize I can change my mind.
Annual re-signing of the notice of privacy policies. If you make a change to the notice, like when we added marketing, research, and fundraising as having to be an opt-out, when we had to change our notice of privacies, we then had to give everybody the opportunity to review the new policy and acknowledge that they had had that opportunity. Okay, but the only one that I renew annually is the business associate agreement. That one has to be renewed annually. The notice of privacy, I have it posted, it's on my web, you know, I have it prominently posted in, you know, a physical place or a virtual, if that's the case. And with the portal that I use, it stays at the top of the client's file so that when they log in, they see the notice of privacy constantly. It's right there at the top. Right? If I ever changed it, I would have to notify them that there's been a change. Same thing for my disclosure statement, which is what we're going to start with next time. If I ever make a change to my disclosure statement, then I need to have clients be aware of that. Does that help?
Yeah, I think so. I think I understand that. I guess the lingering question is, is that enough, or do we have an obligation to sort of remind a long-term client every so often, you know, you can, the last time you're okay with you know, me releasing information and sharing information and whatnot, reminder that you can always change your mind. There's no obligation.
We don't have to remind them of that. No, what I do remind them of is the limits of confidentiality and, you know, taking care of themselves, but I don't have any legal obligation to remind them of that opportunity. Now, if a client is talking about something and like, I can tell they're feeling uncomfortable with something, I can, you know, or like, let's say they had an emergency contact person and I notice who it is and I notice they're not in a relationship with that person anymore. Right? Then I may bring it up to my client and say, hey, I was looking at your file the other day and, you know, so-and-so is listed as your emergency contact. And I'm thinking that things have changed. Would you like to change who your emergency contact is? That's just a best practice then. Yeah. Oh, Sarah, good question. And hi, Sarah. Nice to see you. The MVC, is there a different duty to report to? If I'm a private practitioner, I do not have a duty to report. If I am working for the military, I may have a duty to report, especially if I know that this person's in a potentially risk situation where whatever we're dealing with could influence their ability to function in the role that they're functioning in. I would have a duty to report. But if I'm private, I do not have a duty to report unless I'm self-harm, harm to others, etc. Okay. Can you address HIPAA responsibilities for us as individual counselors working in someone else's private, same policies apply. You have to follow HIPAA wherever you are. If you're a contractor, an employee, a staff person, whatever, you are responsible to following HIPAA. I do think, Susan, for you though, school gets complicated, right? But if you're ever in the school, that can, but in private practice, like I'm going in and I'm going to work for somebody else, Able to is a good example. So I work for a great company. They do a lot of training for us. We get a lot of support, but I'm responsible for making sure that my HIPAA requirements are being met with my clients. Like I can't just trust that Able to is doing their job. That's part of what HIPAA says.
So what about things like the annual audit and those sorts of things? Is that something where you would sort of not abdicate or that responsibility to the owner of the practice?
I would ask if they're doing that and if they have a report of what the results were so that I can see it. But I also am always going to be paying attention to the processes. Do I notice if something gets out of compliance, right? Like, is something not encrypted at the level that it's supposed to be? So I kind of wonder about those things as I'm doing. Like when I first got approached by Able to do some work for them, I scrutinized them. I was like, do you do this? Do you do this? Do you do this? I had a list of questions about how they handled things, and I really did my homework.
Okay. So it's more going in with asking in advance as opposed to signing on and then asking, or then following up as the process unfolds and you notice that there are discrepancies. You're saying more like go in and make sure that they're on board.
Yeah, exactly. Now, somebody asked about, like, I think when we were talking about BAAs, like if you're working for somebody else. So I wouldn't have a BAA if I was, say, a consultant working for a private practice, or like I was a contractor working in private, but what I would have is a contract with them about my, my work. And in that work, we would have some understanding that I wouldn't breach HIPAA. And if I did breach, I would follow the protocols of that agency, and all that would be in my contract with them. Same thing with a healthcare plan. I have a contract with the healthcare plans that I can bill. And in that contract is the language, right? And a lot of places now just build the BAA in. So if you choose to use Office 365, say for your private practice, and you get your own account, it's already built in. You can literally go to Microsoft Compliance and pull off the BAA contract. It's already there. They already have it done for you, right? So a lot of places, if they're familiar with telehealth, and like Zoom, VC, DoxyMe, all of these places we'll be talking about, these tools that we're going to be talking about, they all do a BAA automatically. The only one who will not do a BAA with you is Apple, because they say that they're never going to have a breach. They don't need one. Phone companies fall under FCC. FaceTime falls under FCC, not under HIPAA, which is interesting. I am an independent contractor with Able to. So I work for them 10 to 12 hours a week, same clients. Kind of cool. What else? I'm gonna be about 3 minutes. Did I miss one? I think that was it. Oh, yes, that's a great one, Gwen. Absolutely. And we're going to be talking about that in the diversity, equity, inclusion. There's guidelines for that, about interpreters, about making sure that like PDFs are searchable, your website searchable, having your alt tags for any pictures, all of those things. So yes, absolutely. I'm going to give you a ton of resources for that. My goal really, I can't cover everything. I can't teach you everything, right? But what I can do is give you a toolbox full of tools. And that's what I'm hoping you'll leave this training with. All right. It has been a pleasure as always to see you all. Please remember to fill out your evaluation. Let me throw that back up in there for you. So if anybody didn't capture it last time, well, it's not letting me do it. Why are you not going to let me go back in? Let's see. Let me grab it up here. So anyway, yeah, just know I'm here, and I look forward to seeing you guys again at the next one. And I'll post for the We Men Married people. I'll definitely get this posted in the program office, but then I also will have the posted in the YouTube for everybody else. So. All right, have a great day. Enjoy it. Stay warm.
Thanks.
Thank you. Thank you.
You're so welcome.
Bye, Dr. LA.
You too.